Here.
Dr. Keller,
Here.
Dr. Lakey,
I am here.
Dr. Liberzon, Dr. Martin. Here. Dr. Martinez. Dr. Mayer. Dr. Mitchell.
Here.
Dr. Nemiroff.
Here.
Dr. Newport.
Here.
Brittany Nichols.
Here.
Dr. Pliska. Dr. Potawiltz. Scott Schlacklin. John Scott.
Here.
Dr. Suarez. Dr. Teminga. Dr. Thompson.
Here.
Dr. Vo.
Here.
Dr. Wagner.
Here.
Dr. Wakefield.
Here.
Dr. Wesley.
Here.
Dr. Williams.
Hello.
Dr. Pliska. Thought I saw him somewhere, but maybe not. Okay,
Steve Pliska's here.
okay. So that's 22.
All right. Very good. Thanks, everyone. Several of our folks, especially those.
Yes,
of
I am here to confirm.
the,
In
several-
mind, well as an appearance.
several folks are. So I'd ask everyone just to make sure we mute the computers for those that are in this room. But several people that are involved in state agencies are being pulled down to the Capitol. This is the really busy time for state agencies as final bills are being pushed forward, as the final decisions are being made by the legislature. The end of the session is the end of this month, and so a lot of work is taking place and a lot of people being pulled downtown to make sure that they understand the implications of everything that's taking place. So with that, again, I want to thank those of you that could be here for being here. We have, I think, an important agenda today. We will go through the usual things that we do, but we're also going to spend some time relooking at our governance, making a few changes because of some legislation that will be taking place. We're going to talk about some new research initiatives that we are proposing and talk about some of the changes that are occurring in telehealth that I know is of interest to many of you. I've gotten several emails from folks around this, around the consortium related to those issues. So with that, let's go ahead and get started. The first item agenda, I would ask people to take a look at the minutes. And once people have taken a look at the minutes, we'll need a motion to approve them in a second.
Move approval.
Have a move for approval from Dr. Wagner,
Second, Dr. Ibrahim.
second, Dr. Ibrahim. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 All right,
Aye.
those opposed, nay. All right, it is approved. The next item, Luann, Mary, are you here?
I don't see her on right now, so let me
Okay.
send her an email.
So we're gonna make a quick adjustment here as we make sure that Mary was able to log on. And let's go to the update on from UT Austin on the fiscal agent. I think I saw Linda
here.
here. Okay, very good. Let me turn it over to you.
Sure. Let me share the screen, and I also included the PowerPoint in everybody's packet as well.
Very good.
All right. So we got good news to report. So we don't have a lot of contract activity. We know that there is going to be some changes that are made with some additional budget that we have available, and the fact that there might be the extension on the ARPA funding. So we will be working on those extensions once we get the official word from the state. Invoicing is going very smoothly. We've received invoices from every HRI, at least in one form or another. And so those are coming on a regular basis. And then we had submitted our quarterly financial report last month and didn't hear any follow-up regarding that as well. So the numbers that I'm about to report are based on the end of April when we closed the month. And so this time I went ahead and added the budget as an overlay. So that's where you see the two different colors. Now that we had reporting on every category and with each of the HRIs, I felt that it would be a good way to show the representation of the budget versus actual. So to date, we've spent 15 million of the funding that we've received on the various initiatives. Our primary focus has been about the TChat area, followed by C-SPAN. But there's also been some funding that's been taking place in the CP WE programs as well. So there's the figures for everybody. Are there any questions? All right, well, that's the numbers that we have to report for you this time. I'll stay on the call. If something comes up later on in the session.
Very good. Thanks, Linda. I like that chart, and again, it shows us kind of where we are. As was noted, there's not all the funds have been spent. Obviously, it's just as the nature of standing up new programs, and we're grateful to the legislature for what they're doing in the supplemental bill that will allow these dollars to continue forward. We'll talk more about that a little bit later related to the full budget. But again, any other questions for Linda? All right. Hearing none. Again, we're gonna move ahead and go to 4, and just kind of juggling a couple of things around because of some people that could not be here today. But let's go ahead and go on the go and have the update on the on TChat, and then the internal evaluation and external evaluation. So Luann,
Yeah, Lachelle was gonna
give the update on the TChat update. Very good.
like where we're at in terms of how many schools and
Mhm.
we did, I do want everybody to know that, and if you go on our website and look at the map, you'll see this, but we did reach the mark now where our covered lives for students has gone up to over 3 million, which is an incredible accomplishment.
I'm just going to share the governor's report that goes out each month that shows our progress across implementing TChat across the state. So as you can see, we do continue to make steady progress. There are a couple of regions where we're seeing a lot of onboarding status. That means that there is a PIA in effect with a school district, but the schools themselves have not yet gone live with TChat services. I will say this data is as of the end of March. We should be getting new data today, and then we'll be updating the report by the end of the month. So this is always lagging a little bit as far as where we're currently at. We do, let me go to the next page. This is just a different view of the data that shows by ESC region. We do continue to coordinate with the TEA and with our ESC partners. So we've started delivering monthly reports by ESC region so that they fully understand what schools in their district are live, which ones we're currently working with to onboard, and where are we having troubles getting a response. So that recently started going out monthly, and our hope is that they can help partner with us to reach those schools that we're having troubles getting a response from. Growth over time continues to grow, as well as the population. And as Luann mentioned on our website, you can very clearly see the state that we are covering. We do have some school districts declining services. And some of those, majority of those are because they feel they have existing mental health providers or services, but there are some that feel the lack of space within their area, or they may want to consider at a later date, given other things that might be going on within the school. So we always keep TChat open. If they decline, they always have the opportunity to come back to us later if they change their mind, and we encourage that.
So maybe, Lachelle, let's go back to the first graph there. And as Lachelle and Loanne noted, we are providing this information per the request of the governor's office on a monthly basis. And again, appreciate everyone for the data that you're providing us so we can provide it in an organized way to the governor's office. And we're also providing this to the major legislative offices. And again, I'm encouraged by the progress that's taken place. So we're covering right now about 53% of the student population in the state of Texas, a little over 3 million students. We've set as a goal to try to get to covering every school that desires to have the program by September. Every time that I've said that to the legislature, I've couched that in noting that the major challenge that our HRIs have is hiring the people we need to do that. But again, we're going to need to continue to follow this information over the next, over the next year as we continue to hopefully those charts become. We have less of the salmon color and much more of the green color. And the size of those bars doesn't necessarily mean the amount of the student population, because a lot of times you've been able to get into the major metropolitan schools, the challenges, some of the rural schools and the other harder to reach schools. But just wanted to spend a little bit of time on this chart and just hear from the folks around the table and the virtual table on how is that going and any major roadblocks besides the ones that we've noted so far in moving that forward. I've heard from some institutions, Steve, I appreciate you raising your hand. I think one of the challenges is that it's been hard to hand off students after they've been brought into the TCHAT program because of the lack of other community services for these kids. We've had some discussion whether we need to figure out how do we still prioritize kids so that if there is a child that really needs help, that we'd be able to get them in quicker. But we're starting to see kind of that challenge as we're covering 3 million kids in the state of Texas and the recruiting challenges that we've had in order to get the services as quickly as possible to the kids in need. So Steve, let me go to you.
Yeah, just one quick question. The number at the end, that's the maximum number of districts in our particular regions, right? That's where we're targeting. Like in our case, we want to target reaching out to 1,052 districts. And so far we've got 271 whose status is unclear at this point or planned, right? Just make sure I'm interpreting the numbers right.
Yeah. Why don't we walk through your graph and Lachelle, you want to just kind of walk through what each segment of this graph represents?
Sure. These are a count of schools. So it isn't a district. It is a count of schools that are covered by the districts that we're targeting. So the total number at the end is a total number of schools that each of these HRIs should be targeting to eventually roll out TCHAT services to. The blue, and I mean, on my screen, it shows as green, but on this other one, it shows blue. This one right here is those that are live or active. So these are the number of schools. So in San Antonio's instance, you have 595 schools as of the end of March that we're showing as having live TCHAT services. The orange is the onboarding. That means that an MOU has been executed with the district, but TCHAT services are not yet live. So the school may be pending training, or the HRI might be awaiting district or school direction to initiate the onboarding. Sometimes we hear that the district itself says, we're not quite ready for you to go live with this school. Although, in theory, we can offer services to that school at any point if they come back. But we also, as Dr. Lakey mentioned, have issues where maybe the HRI itself has had difficulties in recruiting staff, and maybe the HRI is waiting to ensure they recruit staff so they can deal with the volume of calls expected if they onboard those schools. Pending, which is a yellow, means that we have had conversations with the district and we have distributed a draft MOU to that district, and you're in active conversations trying to get that executed. And then inactive, which we have very few, are schools that previously received TChat services, but then decided to opt out and not continue services. That's red, which, as you can see, is just very, very limited. Then we have declined. So those are schools, or so a district would decline services, but as a result of that district declining, any schools that fall in that district would then be counted in this number. So if it's a district that has a lot of schools, the impact of that decline is going to be much greater than one that only has a couple of schools. And then the gray is planned. So these are schools that are on our list that we want to target, or districts we want to target. And it could be that we're reaching out to these districts, but we're not getting a response. I know I see that on some of the status reports. Or it could be that we just haven't reached them yet. So we may have emailed them or contacted them, but had no response, but maybe we've only contacted them once. So part of what the TChat groups are doing are outreaching to each of these districts, trying to get that communication back. We have heard some haven't been able to do that. That's why we initiated the TEA ESC level reports. So we're pulling the information that the HRIs give us monthly into a status report by ESC that says, here are the districts that we are having a problem getting a response from. And then we're hoping those ESC leads will go and talk to those districts and help facilitate that conversation or bridge that communication gap for us. Does that answer your question, Dr. Plitzka?
Yes, that's helpful. And I mean, David asked if to talk about our experience, kind of, I can add ours in terms of what, if you want to do that at this point.
That'd be great, Steve.
Yeah, I would say for that 271, that planned, most of them we've had, I think at this point, given that this was as of the end of March, I think at this point we have at least made a single outreach to all the districts. I think the gap in the pending is the most common reason is not hearing anything definitive back. And then that gets broken down to sort of bouncing between different levels of decision-making within the school district, and not always clear who the decider is. And the other is kind of, well, we'll get back to you. And we don't know if we'll get back to you is a polite way of saying no versus they truly are ambivalent about the whole process. We're not getting a lot of questions that already, we're not hearing things, we don't want TChat because. We're not very little. The one exception that we had one district that had a very unusual request. They said they would only sign up with TChat if none of the school district personnel were involved beyond making a referral, and as we could guarantee that all the appointments would be outside of school hours because they didn't want kids missing class. And we said, well, no, we couldn't guarantee that. So they'll probably end up in our declined box. But that was the fact that we were given a very concrete reason was unusual. Most of the time, we're just sort of in this limbo.
I think that's very helpful, and actually maybe something that we need to consider as we portray this data. And that right now, when you see planned, there's several different types of schools that are bundled there, and as you're pointing out, many of those you've already reached out to, but just haven't heard back, and that's different than we haven't reached out to those schools. And so that may be something, Michelle, we can think about as we continue to refine this tool to delineate that gray just maybe a little bit better as the difference between us not reaching out and us reaching out but have not gotten a decision or feedback from the school. Thanks, Steve. How about anybody else? Yep. Sarah?
Our experience is pretty much the same as what Dr. Pliska is saying in El Paso, in our El Paso's region. And then it's interesting because it's kind of the opposite of what you were saying, Lachelle, in our region where the rural schools have almost all signed up. And the district, one of the bigger districts, one of the biggest in our region, we had a pre-existing mental health clinic at.
Mhm.
And so they don't want to check because they have us there in person. So that's like
Yeah.
a completely different. So that might be something to consider when you're, but, and that's probably, I think that's the second biggest district in our region. And then, but mostly it is the ones who haven't signed all the paperwork yet. They've said that they want to join and they just haven't followed through. And so then it's a balance between, okay, following up so they don't forget you and all the other million things that are going on at their school and our school district. And then we don't want to be too pushy.
Yeah.
And say, oh, these people are annoying. Why would we want to sign up with them?
Yeah.
So we're trying to strike the right balance there. So we have a, we do like rounds. Everyone that's not signed up yet, we combine like a T-chat outreach with CPAN outreach, and especially, and it's actually surprising. There's a lot of primary care providers that are on school boards. So we do mention T-chat whenever we do a CPAN trip to kind of, round it out. Plus that's who we're referring back to when someone's completed their sessions and we have them stabilized. Then of course we have to circle back to their primary care provider. So, but yeah, mostly
That's helpful.
you
Yeah.
just don't hear people say, oh, that's a great idea. And then, you never get put on the schedule for the school board meeting.
Yeah. Okay. Very good. Anybody else? Dr. Farmer?
I think it's probably what everybody else is experiencing, but the success that we're having with those districts that have signed up is beginning to influence then other districts that have perhaps been more hesitant to sign up. They're, word of mouth, they're hearing about, they're seeing the success of the program. And thus, then we see them opening up to be more interested in participating. And it is that follow-up. The team we're working with JPS does a lot of follow-up with the districts, and it does make a difference. Just take some time. Take some time for everybody to realize the significance of this program and the potential impact.
Yeah. Very good.
And I'll just share really quickly, just so everybody has an idea of what we are sharing at that ESC level, because you mentioned, districts that you're not getting a response from. So we every month now are doing this, by ESC region. We give this to Julie Wayman, and then she gives it to her ESC leads, who then distribute, or the thought was they would distribute to their districts. But we are very clearly identifying, based on the data that HRIs are giving us, which districts have not responded to outreach efforts, so that they can try, as I mentioned, try to initiate those conversations with those districts to help us to get them to that MOU status, or to get us to an answer if they don't want to participate, which is also okay, just to let us know that they're not interested in T-chat services.
Right. Very good. Let me go to Dr. Ibrahim, then Dr. Wagner, and then Dr. Keller.
Yeah, I mean, for us, kind of a similar experience. The segment which is onboarding is kind of multifactorial. Some of it is not finishing up the paperwork. Some of it is not finishing up the training in the school. Some of it is onboarding of schools. These are mostly in rural areas too. So we have the Dallas district that hasn't really made a decision yet, but we have a lot of these schools in rural areas. I mean, the hope is that in the next coming weeks and months, these would all be sorted out. But it's going to depend on the responses also from schools.
Yeah. No, thank you. And again, I know all of you are working hard to build this out. And it may be upon us to figure out how do we document some of this a little bit better, such as the difference, as I noted earlier, between us having reached out and us not getting a response on this. Dr. Wagner?
So I think interest certainly has increased in the T-chat program. And what it does, though, is it becomes a balancing act of trying to bring in new children to be evaluated while finding referrals for those that are currently in the program. So I think that'll always be something everybody will have to keep in mind.
I think that's important. I've heard that from others as the number of referrals, and we'll get to that in a little bit, has gone up. Thinking through how can we maybe be better at prioritizing kids that really need to get in, while we're having some kids that maybe less acuity, but we can't find a ongoing source of care for them. I think that's something we're going to need to work on. Did that
Especially-
capture? Yeah.
Especially when you're dealing with different school districts, so you have to balance that. One school district could fill all of the slots, and so it's balancing of, I think, severity and then also, somewhat of fairness to school districts.
Okay. Very good. Thank you. Andy?
Yeah, well, I'm really glad we're having this discussion. I appreciate it, David. And I just think people need to, though, frame it with where Luann started us out, that like we're at 3 million,
Yep.
which is pretty amazing. And I know we all know that, but like we're all problem solvers. So I just think that like for the general audience out there and the affect of everybody in the room, like we really need to like be approaching these with like a sense of amazing accomplishment and feeling really good. I would say though that these are going to be the hard ones. I mean, it's like, it's the rule of thirds. Like you got a third that are going to race in, a third that are going to do it if they want to, and a third that aren't going to do it unless you find a way to do it. And then that's not a scientific basis. It may not be exactly a third, but these last ones are going to be super hard. And so I think, it would make sense, David. I think, once we get through session to have a work group where we look at these strategies and we really try to come up with a suite of strategies to use. And we'd be happy to help facilitate that. I would say that while the HRIs have done a great job, there's things that partners like us and others can do to help. I mean, we've worked with, half dozen of medical schools on different things, both formally and informally. We have used our board to pull in discussions with superintendents and others in districts where were high priority districts, for example, and legislative districts where legislators were like, why isn't our school participating? And a lot of times it was exactly the reasons that folks said. It was paperwork. It was like, somebody got assigned and didn't do it, but it was problematic from that legislator's perspective because they're like, why isn't my school participating? So we would bring our board in, we would say, hey, is there a reason you're not doing this, superintendent, given that you're in this? And they would like make it happen like that. So, we all have different levers that we can use. And I think the other one is going to be bandwidth. And I agree with your point, David, about prioritizing. We do, but we also need to look at expanding bandwidth. We're going to be given a lot of money. And if we're leaving money sitting on the table because we've not been able to ramp up capacity to deliver services, nobody's going to be interested in us prioritizing. They're going to be blaming us for not being able to build the capacity we need. And that doesn't mean, I think we need to begin to look beyond hiring faculty. I think it's great that you guys are doing that. That's by far the best thing. But being able to look at partnerships with telehealth-based firms that are willing to follow the protocols and procedures and be subject to your oversight. And I think there are a half dozen groups that we're currently working with, and we've talked to some of the medical school leads about this. And I'm sorry for those of you who are talking to like say we may get more competition for these, but I'm sorry, my dog's super excited. My dog also would like apparently to be on one of these networks, but they're out there. And so I think, David, we can't just look at prioritization. We have to look at additional capacity building processes where we nest capacity up underneath the medical schools. And some of you are going to be more able to do that than others. I don't think everybody needs to do that. But certainly in the bigger areas, those sorts of strategies are going to need to be looked at. And I think this is not really the forum, I think, to brainstorm. I think, we really need a group that can kind of put together a plan. And we certainly want to be part of that group, and we certainly would be happy to support that group in terms of facilitation. And I think that's something we need to frankly have in place by the end of the summer, because increasingly people are not going to be impressed just by how many schools we've got done enrolled. They're going to insist that we move our number of students reached to a higher level. And we certainly can do that, but we're not going to be able to do that just by hiring faculty.
Well, actually, we're hiring predominantly staff, and it's still a struggle. And I would be very much opposed to going to any for-profit telehealth. We've already had several disasters with those organizations.
Well, see, that's not what I'm saying. I didn't mean staff.
Well,
I think hiring staff's great, and I'm not talking for-profit.
That's who they are.
For-profit. That's not who I'm talking about. I want to make sure you're clear about what I'm saying and not characterizing what I'm saying wrong. I mean staff. I don't think you're going to be able to do it by staff, and I'm not talking for-profits. That's not what I'm saying.
Yeah.
But your point's well taken about some of the for-profits.
Yeah, this really is something that is a public trust. And I think what we need to do is look at what we as HRIs can do to improve our salary structure and the ability to attract the people so the program has the high quality that it really needs to have. And I really don't think contracting out, I would generally be philosophically opposed to doing that. I'm just giving a counterpoint.
So I think these are all things we need to consider. And again, I think, Andy, where you started and where Luann started, 3 million kids, that's more than the total population of many states in the United States. It's a large number of kids, and we see month over month growth. And so I want to commend everyone for the ongoing work to continue to build this out. I think this summer is going to be important. I think this summer, converting some of those that were in the MOU is in the process or pending to having them fully implemented will be important upon us. I think documenting this information, as Steve noted earlier, related to the difference between us not reaching out and us reaching out but not getting a response. I think that is important. But we're going to continue to work on the capacity, and I think that's a conversation we can have this summer in a smaller work group of what. And again, I'm not approaching this as fault on anybody. I think you guys are doing amazing work. That this is more quality improvement and performance enhancement, and how do we, after a couple of years with all this experience, leverage what we've learned to and as the challenges we see to position ourselves well to address those challenges. Dr. Ibrahim?
Is there a timeline we gave the legislature where and the percentages we would have completed by that timeline?
Yeah.
So this is many of the schools are going to go out in the summer,
Yeah, I think the summertime is to get some of the legal stuff done, and their people will be there. And again, what we told the legislature after Uvalde is that we would do everything that we could to get this into every school that wanted the program within a year, and that would be coming September. Now, again, we were very clear that there's workforce issues in this, and they understand that. But I think this is where kind of documenting that we've reached out. I think that's something we probably need to be able to tell the legislatures that we've reached out to every school and every ISD, and need to be able to show them that. And if it's on the school to complete their work, then that's different than us not having made the option available to them. And again, we'll be talking a little bit later about the new funds that'll be coming. But again, the legislature has done their part of putting the money in. And we need to figure out how can we be smart in leveraging the resources that we have or could potentially use in order to meet that. It's a lofty goal, but a goal that's important for Texas. Does that make sense, Dr. Ibrahim?
Yes.
Very good.
Thank you.
All right. Laurel, I see your hand.
Yes, I just wanted to say in relation to the conversation, Dr. Keller, is that Luann's team is working on creating a summit this summer for TChat specifically. And I think some of these conversations are definitely the conversations that we're working to have across the state. So just, I wasn't aware if everybody knew that fact as far on the executive committee, but we're kind of working on the schedule and what's going to be part of that summit. And so these conversations are happening. And to your point, like that's small groups and with all the right people in the room, so to speak.
I will just add that this is an operational meeting. It's not an external facing summit.
Right.
We'll be very much looking internally at our processes and procedures, the differences that we're seeing between how TChat has been rolled out from the different HRIs. And it's a time for the operational staff to kind of talk through those nitty-gritty details of, what are the issues, and then how do we best take best practices from certain HRIs and apply them consistently across the broader group.
And with the other caveat that this group here is the executive committee, and so big decisions are made by the executive committee and not by the work group. But that's a good forum for them to pull together good ideas that we can discuss and figure out what we can activate. Andy?
Hey, David, I do think it's a good idea, but in addition to this group needing to make decisions, this is also the group that is holding responsibility. And I think we need to go beyond an internal review by staff. I think that really requires, I think it needs to be very clear that the HRIs are looking actively from their roles at how to move things forward and are taking the lead on moving this forward and not relying on central staff to do this, because it really are this is the whole predicate of this was the relationships that through the training programs, the relationships with providers, the faculty relationships with supervisees, past students who are now practicing in the area, that the HRI should be able to do that. So I think this is good, Laurel, that that's happening and that staff is doing that review, but I think there need to be some more time urgent focused things really on how we bring up accountability. So I think it needs to be a work group of the consortium. Maybe one of the existing work groups could take that on, but we need to be able to point back, next January when we have only reached 4.5 million students, which will be miraculous when we do that. But there's going to be people saying, why didn't you get my school? And it's not going to be enough to say we called them 6 times. It's going to have to say we called them 6 times. We reach out to their blah blah. We did 7 things. I think we need to. So I think it's good. There's no criticism of the thing that's happening, but I don't think anyone expected us to be in the position we're going to be in terms of resources in about a month. Assuming things don't go off the rails. Which is never a foregone conclusion. But I think it's gonna need to be owned by the executive committee. It's gonna need to be owned by the HRI work groups. It's not something we can rely on the hub or whatever. What's the thing called that you run, Laurel?
No. The point was not that it wasn't that. It was that just to Lachelle's point was that we're going to bring that and then bring it forward so people could discuss it.
But I think there needs to be a parallel process of work groups run by this executive committee taking charge of it and saying, we are going to make this happen and not waiting for that analysis. That analysis is great. It will be part of it, but we can't just do that is what I'm advocating for.
Yeah. And I don't think that's what Laurel's saying. And so we will hear from that group and hopefully some good ideas. But the purpose of putting that chart up here is for us to all look at the data and figure out what we can do this summer in our individual areas. And we will work across institutions to figure out how do we bring good ideas, share good ideas across institutions and figure out how do we again meet that direction that we've gotten from the legislature. Dr. Trivedi, let me hear from you, and then I need to go to Mary.
I'll be very brief. I think Andy's point, the way at least I see it, what we've seen in school districts, those that are not signing up often is not like they've proactively decided not to participate. So anything like what Andy was saying, like a work group that can go into a different angle to help them make an informed decision will increase these numbers quite rapidly.
All right, very, very good. Thanks for the discussion. Again, this is something that we're going to be focusing on throughout our next meetings as we continue to move this forward. Let me jump back. I know Mary is waiting in an airport now, and she's been able to connect. So Mary, let me bring you on, and again, really appreciate you in the midst of everything else you're doing to join us. We have. For those of you that don't know Mary, she's the director of telehealth and director at the University of Texas Virtual Health Network. She also works with HHSC as part of their experts related to telehealth and is one of the foremost experts in telehealth policy, former director of the Texas Medical Board. And several of us have been in communication with her as she has been navigating the federal policy and watching what's occurring at the DEA and with the public health emergency and the changes that are taking place. Obviously, a lot of our institutions are concerned and watching that very closely. We thought it'd be good to bring her here so that everyone could hear from her directly the changes that are taking place. And so, Mary, thank you for joining us. And I'm going to turn over the podium to you.
Great, thank you. And yep, there we go. Next slide, please. Thank you for having me this morning. I'm going to quickly go through my very short stack of slides so that I can ensure that there is some time left over for questions. But I'm going to start out by saying I'm fully focused on the prescribing as it relates specifically to your care setting scenario, i.e. prescribing for children in schools or students in schools. So let's start out really quickly at a high level as to why is this necessary, because I think this is important for you to understand going forward. The Ryan-Hyde Act was put in place, we all know, due to an overdose by a young man that he was able to obtain drugs online. This problem has not gone away. It continues to exist. They've got better regulatory authority to try to take care of it, but there are still over 100,000 deaths every year, more than that, related to overdose, and the DEA still sees this as their #1 priority. So there is not going to be a time where the DEA is going to sit back and say, you know what, it's all under control. We're going to let everybody prescribe however they best see fit. That is not going to happen. So go in with that perspective in mind, and the perspective in mind that they are writing these rules for the bad actors, not for you, not for the 98%, not for the 99%. Whether they should be or not is another discussion. But as we sit here today, please know the perspective of these rules is always going to come out from their point of view as trying to have as much regulatory authority as they can to make something as safe as they believe it should be. And that's the perspective we're coming from. Again, you don't have to share that perspective, but just understand that as we go through these processes, that's why you're seeing what you see. It did not help that when we went into the pandemic, a lot of the flexibilities were necessary and absolutely did great things. But then you had a couple of high profile companies, Dunn, Cerebral, all those that had enormous amounts of Adderall prescribing, something like 97 to 99% of the patients they were seeing. So again, as things develop on this, that's what you're going to see. Next slide, please. So this slide is super ugly, but it is a chart that the DEA put out itself. So that is what I am going to rely on. This is the chart that delineates what the telehealth flexibilities were as we went into the COVID-19 pandemic. And you'll see on these that I've always put the links at the bottom of these slides so you can go and confirm them for yourself. But it is familiar to you. This is the process that you use now. You are able to use telehealth to prescribe controlled substances as long as you're doing an evaluation and you're establishing that relationship. And obviously, as long as you're following the standard of care. Next slide, please. So what happened, I'm sure you all know, but the public health emergency expired on the 12th last week, which would have meant that the DEA would have gone back to what the prescribing laws were in place prior to the public health emergency, which, just to be as straightforward as possible, were that you had to see a patient in person first before you could then prescribe to them with controlled substances for the purposes of the Ryan-Hyde Act. The DEA then put up some proposed rules prior to that in March, and I think they believed that they were going to be able to institute those rules. But they had 35,000 comments filed during the comment period for those rules. And as a result of those 35,000 comments, the Biden administration stepped in. And with SAMHSA, because remember, SAMHSA does have a part to play in this, they do a lot of the work surrounding the prescribing for addiction purposes. There was a joint temporary rule issued. And this is what that joint temporary rule is going to allow. Again, the citation is at the bottom for you for if and when you need to go back and look at this. But this is the language from the Federal Register. The Federal Register is where the DEA and any federal government authority has to publish what they're doing so folks know what's going on. So here's where we are. The flexibilities that were in place during COVID-19 are going to continue to be in place there through November 11th of 2023. So you can keep doing exactly what you're doing right now through November 11th of 2023. In addition to that, if you've established a relationship with your patient on or before that date, you're going to continue to have those same flexibilities through November 11th, 2024. Now you can see this is really aimed at long-term relationships, which is not necessarily what you see most of in the program that you're talking about. But for those situations, particularly as you go into the next school year, if you establish a physician-patient relationship with a student by November 11th, you are going to be able to continue to use those same flexibilities without having to see that student in person for another year, for November 11th, 2024. However, after November 11th, 2023, something different will be in place. Next slide, please, for anybody you don't already have that relationship with. This is possibly what may come into effect. And I say possibly because this is what the DEA had proposed. This is their own chart that summarized the proposal that they were putting up that would have gone into effect absent the 35,000 comments. So you can see very specifically, it does not allow what TCHAT is currently relying on as it relates to Schedule II drugs. It doesn't allow it. So that's this bottom piece right here. If you look on the far right and the bottom right, which is a telehealth visit without an in-person medical evaluation by the prescribing medical practitioner or without a referral, it's not permitted. Of course, Adderall is a Schedule II drug. Now, for other drugs, for Schedules 3, 4, 5, and for buprenorphine for opioid use, it is going to be permitted for a 30-day initial visit, but you're then going to have to do an in-person visit required for any additional prescriptions beyond that. We don't know if this is what's going to happen in November of 2023. Because the way that the law works surrounding the publication of rules is that the DEA has to analyze those 35,000 comments and make what's going to be broad responses before they can sort of propose an alternative. I guarantee that's what they're going to be doing in the time between now and November. Next slide, please. So I've told you what's going to happen in the next 6-ish months, as far as the DEA is concerned. But there's some things you need to remember. Number one, this is only the DEA and it's only prescribing. So for example, things like HIPAA from the Office of Patient Civil Rights, that's done. Those flexibilities are gone. All the other things that surrounded telehealth that were flexibilities, unless those agencies have done something different, those flexibilities don't exist anymore. So you cannot rely on the fact that because the DEA has an extended flexibility, everyone else does. Most of them do not. They've adopted different policy, they put in another rule, they've changed the way they're going to do it, but they have not done this kick the can down the road situation that we're seeing with the DEA. So you need to ensure that all of your telehealth pieces are where they need to be. This only relates to prescribing. The number two really important thing, and I know Dr. Leakey is covering this for you, is there is currently proposed legislation in place that if passed could be more stringent than these flexibilities prior to November 11th. We won't know for sure what's going to happen with that until the session is over. And then if they call them back for a special session, if that is on the charge that the governor puts in, again, that possibility still exists. That's just a way to say this is going to require close monitoring at a state level as well. And then finally, what we have in place right now is temporary. the DEA will be working on other rules that will go into effect in November of 2023. We don't know what those look like. We know that it's likely they will be different than that chart that they originally proposed, because if they weren't going to be, they could have just adopted those. But that's where we are. I believe that leaves me about 15 minutes for questions. Next slide, please, which I think just says questions. So I'm happy to answer any questions at this time.
All right, very good. Alex, I see your hand. Let's go to you and then we can go to Andy.
Hey, thanks, Mary. I was wondering if you can share what are some of these state rules that are more restrictive that are in play right now?
Yeah, Senator Campbell, along with Senator Shortner, have filed a piece of legislation in response to the first slide that I put with some of these companies that were prescribing large amounts of drugs to particularly ADHD care situations for those under 18. And there's a lot of moving parts to that, most of which don't apply to you, because they relate to, you can't incentivize a provider to prescribe certain things. A patient can't choose the drugs that they want, et cetera, et cetera. The things that do relate to you come down to consent, particularly in relation to parental consent for treatment. And whether the parent has to be present or not. My understanding is in the substitute language on the Senate side, the TCHAT program is going to be exempt. But again, everything's in play. You never truly know. And then the secondary thing is the DEA's rules as proposed, even if they had been adopted, did allow for a prescriber to accept a referral from another physician or another person with independent prescribing authority. And if that person making the referral had done an in-person exam, the physician or care provider accepting the referral did not have to repeat that in-person exam to issue a prescription. That's what the DEA had. Originally, this piece of legislation did not allow that. The person writing the prescription also had to be the person who was conducting the in-person exam. Luckily, I believe that the substitute language that we worked with Dr. Lakey and Sean to allow that did make it into the sub, but again, we won't know until it gets through the House. And again, this may not pass, right? We're down to the last little bits of this session. We just don't know. But that's what was proposed and I think is currently there. But again, Dr. Lakey probably knows more about its current status on the state side than I do.
I don't have anything else to add. All I would add is I think there's a sensitivity by the legislature that they not do something that hinders our ability to provide these services. And so they have, again, in one area, put a complete exemption for TCHAT in the consortium and have taken feedback on a variety of other items.
Yeah, just to be clear, the exemption relates to consent, not the prescribing itself.
Yeah. Andy?
Well, Mari, thank you so much for that overview. And I think we're really fortunate to have this level of expertise around this. I'm glad you're following. I would just add maybe two things to consider as we move forward. One is that, big reason those 30,000 things went in is groups like us and other groups have been working actively to push back on this because we do think that the restrictions, if they're fully reimposed, will be problematic for care delivery for a lot of people that are, and I think you can also, that are at highest risk. I think you look at an email that SAMHSA sent out last week, which moved away from SAMHSA's historic stance on requiring MAT, full comprehensive MAT as opposed to just medication only, and which I think is a good thing for SAMHSA to say, kind of taking more of a comprehensive harm reduction approach. And I guess I'd like to make the suggestion that as this goes forward, there be a work group in preparation for November that looks at this and that includes our internal experts like Jennifer Potter, who, I think is, one of the nation's leading people in being able to think about how to responsibly weave telehealth in. Because while there's certainly impact on us, because a lot of us are thinking as child providers about ADHD medications, by far the biggest impact is going to be when it comes to opioid use disorders and other substance use disorders. So I think we need to be looking at the implications for both, because certainly some of our older youth who are participating, as well as some of our younger youth, unfortunately, are involved with addictive conditions that impact their mental health functioning. So I'd like us going forward to, in addition to the expertise we brought together around ADHD, to also include, and I think Jennifer can easily do that, and then make sure that we have that, so that we're thinking through these options, because it was going to look different for ADHD treatment than it is for a young person with an opioid use disorder.
Yeah, and let me say that SAMHSA and the DEA generally don't agree. That's just the case.
Yeah, I know. We know.
Yeah. I know, I'm saying for the rest of the group, they don't get along. Their legislation generally does not line up. The way they interpret does not line up. And so it is, just to echo what Andy Keller just said, it is extremely likely that you are going to see two different standards, one for substance use disorder and one for everything else. And they do have the federal authority to do that because, right, the CARES Act and some of those other things make it very clear that they consider substance use disorder to be a separate and unique animal. So there is authority for that moving forward. So I fully expect there to be different rules for that than everything else.
I think that there's going to be a lot of discussion around this. So there's going to be, this was an unprecedented level response. So while I agree the DEA is very powerful, there's other very powerful interests that are pushing back on them. And I will just go on the record saying, I think the DEA really fails to take into consideration contemporary clinical practice in these rules. So I think while, I think we need to obviously follow exactly what they're saying. And I know you acknowledged this earlier, David, that there's a range of perspectives, on just to say, we are going to work actively at the Institute to preserve as many of these telehealth options as possible, because we think that while these isolated examples of where people run into problems are problematic, it's just as problematic for people to not being able to access care. And I think the DEA just doesn't weigh that. So I think obviously we will all follow the law exactly. And I love, Mary, your leadership on that and making sure that we're well acquainted. But I think our perspective on how all powerful the DEA is probably less, we're hopeful the DEA is not going to prevail and have this dictated by, a sort of a enforcement legal perspective as opposed to more of a medical perspective.
Let's go to Steve and then to Sarah.
So I think, one of the dilemmas here is that you have childhood and adolescent ADHD that still by and large is undertreated, or at least not adequately treated. And the ACAP and various other professional organizations have been working on that for many years. And I think we were making progress against this backlash of, quote, there's too many kids on medicine, which has always been a myth. But then with the pandemic and the emergence of the for-profit telepsychiatry, we have this other bolus of adult patients who've been coming in requesting stimulant treatment. And the field is in a dilemma about how the appropriate way to diagnose adult ADHD. So in DSM, adult ADHD still requires documentation of childhood impairment, and that can be done by having a history of being treated as a child or adolescent, history of school performance. That's usually obtained from the history from the patient, who can, if they're eager to have the treatment, can always report that. And there's I would say it's a minority, maybe some would disagree, of psychiatrists who say, no, you don't really need a childhood onset. That's not valid criteria. I'm just decided on my own that there's adult onset ADHD. And then you see people who've actually had a history of no problems with inattention or impulse control problems in childhood or adolescence may have in fact superior levels of functioning, but they're still getting stimulant medication. And it's the tension between these two things where both things are true. On one hand, patients need treatment for ADHD, they need access to stimulants. And on the other hand, there's a subgroup that is trying to divert. I think for stimulants, the most common reason that adults want to divert is to combat fatigue if they're working long hours, for weight loss, and in rare circumstances to actually get high on the medication. So how this is going to be resolved in a rational way so that we maintain all the advantages of prescribing remotely, while at the same time, I agree with Mari, there has to be an element of protecting the larger public from inappropriate diversion. And we're trying to do that in an era where these kinds of decisions are having to be made in a very polarized environment. So it's going to take a lot of work by our various professional associations to shepherd this process along. And I agree with Andy that we can't let the DEA be the final decider, but at the same time, we've got to acknowledge that many of their concerns are real.
Very good. Sarah?
Thank you. I wanted to make a comment that these kinds of restrictions overwhelmingly affect our rural communities, and many of which do not have clinicians in those communities to do an in-person evaluation. And so I just want to say that for the record here, that we're really focused on that advocacy as well. And that Ryan High, this devastating thing that happened, he did not get an exam. This was a very different thing than telemedicine and telehealth. And I think we need to continue to say that when we are educating about best practices, that we are recommending and contributing to and participating in an exam for everybody that we serve, and prior to a prescription, which would be best practice and appropriate. And we are improving access to care. So I agree. Well, I think the DEA does have the final word on this, and we should follow those things, that we have space here to also educate on best practices and current standards in care.
Right.
Let me say very quickly absolutely. I think that the tension is just that there is no way to write a rule that says, hey, only the good doctors can do this and the bad ones cannot. And that's the challenge that they're facing. But it's absolutely the case that the comments and all of this are what allowed for this additional flexibility to occur. One thing that you might consider as a group when you're talking about advocacy, and I've had this conversation with a lot of people, is you might want to look at what would work for your scenarios rather than trying to fix it for the entire world, because incremental change is an easier thing to achieve than it is to try to change the entire bucket. I mean, that's obviously up to you, but I truly think that the DEA could address the vast majority of this for programs like TChat and for things like in-person treatment by saying, if the patient is in a location that is certified, licensed, or registered by the state, then these restrictions do not apply. Because then you would bring in every school, you would bring in every long-term care facility, you would bring in every clinic that had a license and things like that. And it is not a wholesale change, but it certainly would allow programs like what you're talking about to go forward without the necessity of having to argue for every other use case in the world. Which is currently part of the thing. How do you thread that needle for the next step? But that's just an FYI. And I've got time for just a couple more questions if there are any.
And David, I meant to also make the point that a lot of this may also affect some of our CPWE relationships. And so want to make sure that we're looking at it from that perspective as well, especially with state legislation that might, if it's only carving out for T-Chat.
Okay. Israel?
Well, I just wanted to say that to second what Steve was saying, I think his comments were very important and very insightful. I think while advocacy is important, we need to be careful that we advocate the right thing, that we understand the complexity. And I absolutely agree with Mary's position, as they say, in the best case policy is an art of possible. And if we can get whatever regulation needs to be done so we can continue doing our job, prescribing the Schedule 2 specifically even for children with ADHD and not having at the same time ability to expand it to adults, that's perfectly fine with me. So we need to be as flexible as possible to get whatever we can as fast as possible to provide the critical care that we need to provide, and not an absolutist kind of approach. So I just wanted to say to Steve, thank you for making this complex case for what we have, how we have to see it. And to Mary, thank you for helping us to move ahead with getting what we actually need.
Yeah. Well, thanks, Israel. I appreciate your comments. So Mary, any last words? I know you have a plane to catch, but anything you want to say before you finish today?
We will be circling back, obviously, once the legislative session is out, assuming they do not call a special session. I will be sponsoring a hour and a half CME on this on June 7th. And hopefully we'll have more firm answers for you at that time. But it's free to register. It will be online, and we'll be able to better sort of guide you through what happened at the state level at that time. And obviously, always feel free to reach out to me at UTMB. I'm always happy to help. Thank you, Dr. Lakey. I'm going to log off now, and I hope you have a good rest of your meeting.
Thanks, Mary. Again, appreciate you being here today. All right. Let's now, we're going to jump a couple things, move forward and go to the internal evaluation and the folks from UT Austin.
Yes, hello, thank you. Yes, thank you all so much. And thank you all for the discussion earlier this morning around T-Chat and the challenges and accomplishments that have been happening of late. And a big thank you to all of your staff who do such a great job of getting to the fine details of where all of those different districts stand. And I know we ask them lots of questions and try to get lots of data from them, and we really appreciate being able to have that real-time data. I was just going to share on behalf of David and I a couple of updates that we're working on. One of the important ones is we're working to build out our team a bit. We are hiring 2 new staff members. One of our positions is for a data manager. That position is now closed, and we have interviewed a number of well-qualified people. So hopefully by the time we meet next time, we will have somebody new to introduce you to serve in that role. Additionally, we are hiring another evaluator for our team who will focus primarily on T-Chat and some of the related ARPA projects. That position is still open. So if you have folks that might be good that you know of who might have an interest in being an evaluator on the team, we hope you will send them our way, because we are continuing to look for the right person for that role. As it relates to that work, we are getting ready to partner with Lachelle to have some discussions with your teams about the best data and data visualizations that we can start to create so that the teams feel like they have the information they need to improve their operational capacities and sort of know in a real-time, at least monthly way from the data about both programmatic activities as well as outcomes, and have that easily available to everyone. So those conversations are going to be starting soon. We're really excited about that, and happy to be prepared for when our data manager joins us with some real concrete ways that they can contribute to this work. We're also excited to be planning for the end of June, where we expect with the end of the residency wrapping up, and we expect to have many more experience surveys from those residents, and we'll be preparing for that, as well as the opportunity to interview and understand some more about the future employment plans for our fellows. So an important time period coming up. We're also working on completing our FY22 brief report. The evaluation report has been turned into UT Systems, but kind of capturing some of those data metrics for posterity's sake. It will probably be coming to this executive team next month, hopefully, to review that document. And then lastly, just a spirit of appreciation for the opportunity to learn from each of the HRIs as you share about your ARPA projects and some of those early lessons learned. We are kind of listening in and benefiting from those conversations about the ways that these programs are rolling out and the successes and best practices that have been developed from that. So that's kind of what I guess I will share this time. I'm happy for any questions.
All right, very good. Any questions for Molly? I don't see anything, but again, thanks, Molly. You guys have been very helpful to us as we've sent a couple questions your way as related to the legislation and, legislative session and getting us, on the report we do for the governor's office and a variety of other things. It's great to have you here. So thanks. All right. Let's go next. Laura, I think I saw you at Savas and on the external evaluation.
Yes, and we do have slides today. I don't know. Great. Thank you for pulling them up. So I will walk you through them. And so we have a number of different things going on. The first slide is about our dashboard. So we were working a lot this year with the internal evaluation team and cost teams on the data cleaning processes with trait and giving feedback on the quality of data. Now we have gone back to our dashboards and we'll be continuing to update them monthly. So we thought we could give you an update on that. The first, just to reiterate, the goal of these dashboards is to provide now ongoing monthly updates on examining access to the services in terms of availability. So for TChat, the dashboard shows the clinics, the schools recruited, and for the CPAN program, the clinics reached and recruited. So I can pull those up. We are also doing this to show where they are located geographically with an underlying metric of the Child Opportunity Index. And what I don't know if you want to click on the TChat dashboard. You can open it up. It takes a little time to upload, and I think this was all sent out if people want to access the dashboards themselves. I don't know if you can click it out from here. If not, I can always open my screen. There you go. Okay. So, so here you see the TChat dashboard, and the schools recruited are indicated by the dots. And you can see that on that, if you could always scroll in, the high means that they have a child. The Child Opportunity Index is high, meaning that they're doing better, they're more well off. It gets lower and then red in the red zone, so lower opportunity. If you click on these boxes stacked on the right-hand corner in the gray toolbar, yeah, you can see there. You can click what kind of stage the schools are in. So if they're active schools, if they are planned for recruitment, and this is to help the HRIs identify who they want to try to work with or call up, and they can click on the circle themselves also to get more information about the schools. And so this makes it easy for them to figure out next steps in terms of recruiting or reaching out and doing retraining. So this is supposed to help guide implementation and planning. If you go to the CPAN dashboard, it's similar. Sorry, a lot of clicking here. And the CPAN one, the one thing I'll call to your attention that's a little different is that we are able to model here the increase in clinics recruited in that location. The circle gets bigger. So you can see by the circle shape, more or less, you can visualize where your greater density of clinics is. And this can help with recruitment also, if you wanted to see what areas you may be wanting to target. Of course, the population density also has something to do with this. But you can also use the Child Opportunity Index background to also help identify areas that could be high need according to low opportunity, if you wanted to target those areas. So this is supposed to just be an easy way to visualize where HRIs are, and we'll be working to get this information out to them. I don't know if you want to stop and ask questions. I can go to the next slide and we can always come back. The next slide is about how can we use this information to do more evaluation about accessibility. So we're working on our team with some spatial analysts who are working to create a measure of the population in need compared to, or the demand for services compared to CPAN services available. So creating actually a metric out of this, with this geographic description in mind. So the method used for this is called a floating catchment area based methodology. These are methodologies used for space to measure spatially accessibility. And so for the CPAN and TCHAT programs, what we're doing is the method includes 2 steps, and what we're evaluating is the geographic variation of the needs. That is, how many adolescents may need psychiatric consult services within Texas by county area or census tract area. And then we assess the current supply. That is, based on the current geographic distribution of the participating clinics in CPAN, what is the supply? And so we create this accessibility metric from population in need to CPAN clinics and availability, the number of CPAN clinics. And this is right now, we're in developing the methodology. So we don't have results from this. I'm just explaining the methods that we're developing to be able to give you more results. So for example, the methodology we're developing, we're using a sample of clinics that were enrolled in 2022. So we determine the supply to demand ratio for each clinic, CPAN clinic, and we sum all supply to demand ratios within each of these points of demand, for example, the Texas County area, to show this measure of accessibility that accounts for availability and demand. Availability and demand. This is a methodology that has been used that we're refining for CPAN. So we could get into saying, well, what is the demand for certain types of highly reasons for calls to CPAN. So if ADHD was a common cause, we could look at what is the estimated prevalence for ADHD in an adolescent population, and then model that number of accessibility. So those are some ways it can be used. So this is one thing that our team has been working on, and we can present more on that later. And as the methodology becomes refined, we'll start applying it. So that is one update. And then the next slide is about our surveys. So in addition to looking at the CPAN and TCHAT recruitment and getting accessibility of services throughout the state, we're also looking at some of the implementation measures in terms of fidelity and level of implementation within HRIs. So the way we do this is we created a sampling frame for surveys to get a cross sample of respondents again for year 3 of T-Chat and CPAN implementers at school sites and clinics. Our T-Chat surveys went out. They just went out. And then our CPAN surveys will be going out early next month. And our goal, again, is to get 300 respondents for each survey. And the next slide is about our CP Week qualitative interviews. And we have been getting feedback on our qualitative interview guides to make sure that we're focusing questions on the goals of the program, to make sure we're asking appropriate question and getting more up-to-date responses, and to go more in depth to understand the trainees' experiences, and that's the residents and the fellows with the CP Week program, looking at the perceived impact of the program, including how it influences their specific career plans in community mental health, the satisfaction with the program, recommendations for quality improvement. These in-depth interviews we're planning to conduct in the next month. So that's moving forward. We'll do 12 to represent someone from each HRI. And I think we have one more slide. Yep, that was it. Okay, so any questions? I know that was a lot. We have a number of buckets we've been going forward on. So we welcome any questions.
Very good. Any questions for Laura? All right. I don't see any hands. So again, thanks for all your support.
Thank you.
Let's move next to the update on communications, and Melanie. I think I saw you a little bit ago.
I'm here. Thanks.
Okay.
Let's see. I'm going to share my screen. Okay. So this presentation, I am focusing on some things that we have in the works to share with all of you. Let's see. So first thing, this is Mental Health Awareness Month and the third anniversary of CPAN. So we have created materials to emphasize those events. So we're amplifying Mental Health Awareness Month both through the digital outreach and the social media posts. So you will see these outreach materials perhaps come up either on Facebook or different digital areas. You may also see for the anniversary some social media posts. I will say that our social media, when you all share it and like it, either on LinkedIn or Facebook, it definitely goes out to a larger network of people. So just a reminder to do that. This is what we're doing for the social media. We are focusing on the third anniversary. The first thing we've done, and all of these are couched in the formative research that we did for the motivating factors for clinicians. So, or any of the barriers that we heard. So one of the things we talk about is that it fits into your day, and we have 3 easy ways that you can do that. We're sharing the most main reasons why people are calling CPAN. We are encouraging providers to share it with their colleagues, because we know that providers adopt behaviors when their colleagues are endorsing that. We also are sharing the on the anniversary, which will go out on May 19th, since May 20th is a Friday. We have the stats that are very compelling, with the number of consults and patients served. And then we have this banner, Happy Third Anniversary and Happy Anniversary, which we have put up on the Facebook page. In addition to this social media, one of the things that we're doing is coordinating it with the HRIs. We have a community of practice 4 times a year with the HRIs. And this past community of practice, when I was with the coordinators, I spoke to them and shared this information. We gave them an email blast content that they can share as well as a visual. So it looks like a uniformed and united effort across the state to amplify. In addition to those pieces on social media, another piece that we have done is that through the CPAN account, we have followed 147 accounts nationally, locally, and statewide. Here's a list of some of them to, again, enhance and grow the network. We're spending a lot of time because we hear very positive things from the clinicians about the free CMEs and other educational opportunities. So we are sharing those as well. We are sharing some of the PeriPan education opportunities through the CPAN channels. Anything that has a call to action that can go statewide for PeriPan, which is generally the education pieces we are doing on the CPAN social media. What's next? So one of the things that we're focusing on for PeriPan next, this is draft, but I'm showing it to you. These are draft materials, is that for the 4 HRIs that are working with PeriPan, we are in the process of finalizing a direct mailer that will go to all of the OBs and also to the CPAN enrolled clinicians about PeriPan. And it will provide them with a magnet that's over here that is modeled after a flyer that we gave to the PeriPan HRIs that they requested around just a call number, a reminder. And then we have the program highlights and we have a QR code that is to call. We also purchased vanity URLs, texasperipan.org, texasperipan.com, texascpan.com, and texascpan.org, and they direct right back to the site that we have been using. So this is something that's coming up. We're also working on other PeriPan foundational and outreach items such as the OB provider toolkit. Tomorrow, we are doing the filming for the PeriPan video in Austin, and we're excited about that. We're continuing to work on stakeholder partnerships and the CPAN and PeriPan web pages as well. We just finished a very detailed SEO report on the CPAN web page and are working to implement some of those changes and updates. And that is what we have been busy doing. Happy to answer any questions.
All right, very good. Any questions for Melanie?
No questions, but I do want to plug the fact that we have an open communications position at UT System, and we are still recruiting for that. So if you have anybody that you feel would be appropriate, they would be working with Melanie and with our HRIs to help coordinate all of the communication work that goes on across the 12 institutions.
All right, very good. Any other comments or questions? Seeing none, again, thank you, Melanie, for all the
Thank
support.
you.
Thanks for being here.
My last comment will be, since I still have the floor, is just a reminder, like I said, if you follow us on Facebook and on LinkedIn, to like and share those posts, because we know that when you do that, a larger network of clinicians see them. So thank you.
All right, very good. So let's move next. And this will be from me. And Michelle, can we put up the document itself instead of slides for the what I'm entitled the New and Emerging Children's Mental Health Research Initiative? And so a little bit of background on this paper. We sent it out on Friday. As we discussed previously, over the last several years, we've developed 2 what I think are very successful research networks that have linked all of our HRIs, one focused on depression and one focused on trauma. But it's clear to me in a variety of forums that one of the major challenges of building research capacity in the state of Texas is that the challenge of young investigators to get to the position where they can bring in their first NIH grant. And if you look at the NIH on their website and look state by state, Texas doesn't do as good as we should related to NIH funding in general and in mental health research in NIH. And that was part of the goal of the consortium when we put this together, is to position Texas better to be successful in obtaining NIH funding for all of our institutions. And as again, I think the work that we've done so far is in the right direction. But we need to do something, I think, to strengthen the young investigators. And so as we put our budget together, we put in some extra dollars. It's come down a little bit, and we'll need to, after the session, figure out exactly what the dollars will be. But it'll be about $4 million to invest in something different, something new. And I think this is a real potential strategic opportunities to equip not everyone I'd like to, but be able to equip some individuals so that they would be successful. And we've had conversations, and Israel, I see your hand, but let me go through the initial, and then I'll circle around to you. And as we've talked about this, we presented this at the last meeting, and it seemed like there was significant support from around this table that this was in the right direction. And so I, with the help of others, we put together a document that outlines our initial thoughts related to what this could look like. This isn't final. I've gotten some input from individuals saying that they would like to see it go in a maybe a little bit different direction in a couple of areas. And I think I didn't want to, in a closed group, make those determinations. But I did send this out earlier in the week to some people here, just to get an initial reaction if I was in the right direction or not. And I got the impression from them that I was in the right direction, but there's a couple of the particulars that we could discuss. And so I'm not going to read this to you. Why don't we go to the next page? But the background is the background. It lays out kind of where we are. Why don't we go into the preliminary guidelines? Because I think the devil, so to speak, is in the details. And again, I've tried to frame this so that it's aligned with our conversations we've had here, but also in the conversations we've had with the legislature. And so I'll go through these line by line. I'll go through all of them, and then I'm going to come back to the top, and then we can discuss and adjust where needed. We won't do the final adjustments today, but I want to get this out to you because, again, it looks to me that these dollars are going to be put into the budget. Those dollars would become available come September, and so early after that, I would like to start moving forward on this initiative. And so the first kind of basic guideline is that the proposals will be focused on research topics identified by Texas HHSC in partnership with our executive committee, that they would focus on improving the mental health systems and services in Texas. And that, like we've said before, that this research isn't really basic research, isn't drug studies, because that has been an important item for the Texas legislature, that the work that we do should be focused on improving the systems of care here in the state of Texas. That the second guideline said that proposals will be accepted only from our institutions, that the principal investigators must be based at our institutions, but they could partner with other Texas-based investigators at non-consortium institutions. Again, the goal is to build the capacity of the 12 members of the consortium. But if the investigator needed to partner with another academic institution or somebody else, that would be allied. But I want the principal investigators to come from the consortium institutions. Third item, and this will be an area of some discussion. Again, we had talked about focusing this on young investigators. So the principal investigators would be at the rank of assistant professor or below, would be given priority for the funding. And I said priority, so there wasn't, Charlie, I know this is an area that's important to you for us to discuss in a little bit. It doesn't eliminate other folks, but it would prioritize the young investigators. And again, we'll circle back around to that, but there's been some discussion of whether we should make that a little bit broader. Again, the drawback of making it broader and that everyone else is a priority is, and then you lose some of the ability to really prioritize the young investigators. Fourth item that I put in here, in an effort to enhance research collaborations, proposals that include more than one of our consortium institutions are encouraged. Again, trying to get us to collaborate across our institutions. 5, that we'd set up an independent peer review committee consisting of researchers based outside the state of Texas to review and score the proposals. The consortium's executive committee would appoint that peer review committee through an application process. For people that have had experience in this area, they would review the research proposals and make recommendations for funding to the consortium, but the consortium executive committee would have the final decision-making authority in awarding grants and could consider other factors. Again, the reason I said this is that I don't want all these to go to one institution or a couple of institutions, but want to make sure, again, with these state funds, that we make sure that we do as much as we can to have diversity there, but have that peer review process as the cornerstone of putting this together. And that we would, again, like Separate does, reimburse those individuals for their time and effort for reviewing these grants. Number 6, the goal would be that these would be one-time initiatives completed within the 2 years. Really would position these individuals to get the NIH grant. Would not want them to become an ongoing funding stream that they feel like they're entitled to have, versus getting them where they get the preliminary data and move forward if they have been successful. Okay, and the assessment of future research funds derived from the program would be conducted every 2 years. Number 7, and then this is where we can have some discussion. We said that total cost would be limited to about $250,000 per year. That would be the top. There may be some that are below that, or $500,000 for the duration of the proposal. There's some people that would like that a little bit higher. Again, the pie isn't going to get bigger significantly, and so the more we put in that, the fewer people we're going to be able to fund. I think a lot of young investigators, with a K award is less than that, and so I think this should be at a level that should be very attractive to our faculty members. We also said that these individuals would need to dedicate between 25 and 50% of their time and effort to completion of the proposal. A couple of the people that I asked about that would like that to be a little bit lower. Again, I think that is something we should discuss as a group. As you make it lower, you have to understand that the other obligations will pull them so that this becomes less of a priority. Again, that's why with K awards, a lot of times they have a significant proportion that is dedicated, that protects that young investigator's time so they can do the hard work over this 2-year time period to get that NIH, that grant that can be at a lower percent effort. And we put in that indirect costs would be limited to 15%. Separate's is at 5%. We've tried to limit indirect costs here. So this is a little bit different. Again, I know a lot of our institutions that there's always that concern that if there's no indirect costs, this becomes an easy way potentially get funds versus going out for the full grant. I put in here, we go to the next part here, that we would couple this with a mentoring program. And this came out of the conversation we had last time. There are several folks that said, wouldn't it be nice if we did this, that there's a way to link these individuals, make it something that was significant, like a named scholarship program, be able to bring in on a regular basis these individuals and work with them as a cohort to make sure that they are successful. And so we said that all PIs must identify an experienced mental health researcher mentor The primary mentor would have to become from one of our consortium institutions, but doesn't have to work at the same institution as the principal investigator. These investigators will convene together twice a year for peer review, learning. The cost of the travel could be covered by the grant, and up to 5% of the funds could be used to offset the time and effort of the mentor. And again, it thought that we needed to put some time there in order to make sure that senior faculty are willing to do this, and that they see value there. And so that's the basic proposal. There's a lot of details here that can be adjusted, the percent effort, the amount of money, a couple of additional things, but again, the direction is to have some way that talented people at your institutions that aren't quite ready to get the NIH grant would have a mechanism so they could get some funding to get the preliminary data they need to become successful. And so, Israel, I'm going to start with you, and then Charlie, and Wayne, but that's the basic idea, and would love everyone's feedback. Israel?
Yeah, so first of all, I would like to commend you and others because I think it's a very important and very good initiative overall. So I'm in strong support of doing that. With some caveats, and the first caveat and the most important one for me is I think we should not be, everything should be, can be discussed in the terms of priority, but I would not use the point one as exclusive thing, because clearly we are also trying to look on outcomes. And so in my mind, if we have a successful young investigators that can be supported by this process, it should not be limited thematically. Obviously, it cannot be, completely basic science kind of thing. That's, to me, it's clear. But if we're talking about that should be directly relevant to children mental health in Texas and how the consortiums contributes to that, and saying that's the requirement without going into details on other things, I think that should be sufficient. We are moving on with the intervention studies right now. For example, there are proposals from Trauma and Depression Network and so on to look into that, and that might be slowly developing. So I'm strongly encouraging and would like to see the first point modified, as I say, in priorities and in terms of relevance to.
David, could we see that again? I just want to be clear on what Israel's suggesting.
And
we can put that up.
Yeah, and the other thing that I wanted to mention that I would like to make that as flexible as possible. So if a little bit less than 25%, if the person has only 20% to put in, but they are good people that will be, I think we should not exclude that possibility. I think, I understand this is not a K award, but it's also 2 years and it's not 5 years and so on. So I would, but it's also more money to do the research actually. So I would strongly support maybe decreasing the requirements from 20%, or even if everybody feels 15%, also fine. But I would think that 20% probably will be sufficient. But to me, that's a detail.
Okay.
I know it's not my turn yet, but I'm not sure what Israel's recommending as a change for that first one. It wasn't clear to me.
The recommendation for the first one is not to put it in those.
Could you show it? I can't see it.
Yeah.
No, you went too far, too far.
It's about mental health services.
Yeah.
What
go to the first. Go down a little bit further. right there. The
That's it.
proposal will be focused on research topics identified by HHSC in partnership with the executive committee. They'd be focus on improving the mental health systems and services in Texas, and that we wouldn't do basic research or drug studies that wouldn't be eligible. And again, I have modeled this out of the language that we've told the legislature on what we're doing, and we'll have to be careful that we are true to our word with the legislature and what research is and isn't. We've kind of focused more on health learning systems. That's something the legislature will support.
I would simply remove the B. That's my point.
I don't know if I can remove B. Again, I'll take a look at it and think through it. Again, Israel, I'm just being very honest. I got to make sure that I use the dollars in the way the legislature felt comfortable from the beginning to use. And if I stray from that, I think that wouldn't be good. I think we can look at kind of what that health system research can be and be a little broad, but those things under B are very clear to me from the legislature as lines I need to not step over. Okay.
Yeah, my suggestion was to try to make it as soft as possible and maybe not highlight it as clear. But to me, if you feel there is no way and you're going to get pushback and there is no way to respond to pushback and saying, okay, if people insist, we'll put it back in, I would not, because they will not see that this discussion, they will just see the proposal. And in my mind, not getting the least limitations that we put in, the better it is, the better it allows us to support our young faculty. And that's a shared goal for us.
Yeah, and it's a shared goal. And I hear you all think about it. I'm also going to be very true to my word to the legislature and make sure that they feel very comfortable that we are managing this in a way that they feel good about. So Charlie, go to you next.
Thank you. Let me first say that we've come a long way in the consortium when we first talked about research to where we are today. We owe a great deal to David for being able to thread the needle here to get us to where we are. This is a remarkable development. So I have several comments and recommendations. The first is, to Israel's point, I think that we can talk about translational research very comfortably, Israel. What we're not going to talk about is basic molecular neurobiology or animal research. I think we could talk about clinical research. We are, as you said, already doing outcome studies, but we're not going to be doing pharmaceutical company sponsored studies. And in between the goalpost here is room to do pathophysiology, prediction of disease, treatment response. Those things may be possible. So I agree with David, and we have to adhere to the spirit of the proposal. Secondly, I'm going to argue that we should create research career development awards, literally, and that at $100,000 per year, we can support, just like the NIH, 2 years of funding for assistant professors to protect their time so that they will actually be able to engage in research and have a small research fund associated with the Career Development Award from the state of Texas in order to work with one of us, with Israel or Maduka or Carol or Jair or Wayne or any of the other great researchers, Joe, any of the great researchers that we have in this state. And we get a lot of bang for our buck. And the metric, part of that 2-year experience, would be mentoring them to either apply for a K award of their own or to apply for an R01 or an R03 or an R21. And I think we can do that. And we'll get a much bigger bang for our buck. I think $500,000 is a lot to give an assistant professor. But I also think that there are associate professors that have never had an R01 that we have recruited into our HRIs who now want to do research, and I think they should be eligible. People who are associate professors, or for that matter, even full professors. Sarah, um, who now want to spend some time doing research and should be eligible for this funding. I'm more worried about the fact that we're not going to get enough applications relative to the fact that we're going to get too many. So I think, the devil's in the details. I'm willing to debate with you whether someone who has one NIH grant shouldn't be eligible for additional funding to move their career even further ahead. But I'll just throwing those ideas out to you.
No, I appreciate that, Charlie. I think all that can be discussed. Again, I want to, focus on how do we really move research forward in Texas, young investigators, if it is an associate professor now that has done a lot of clinical work and now sees an opportunity there. I think that's something we can consider. I wrote it as priority, not as exclusive, but I'm happy to have that discussion. What I don't want is all of a sudden senior researchers who can get NIH grants start using this pot of money, and that which sometimes happens with cancer dollars here in Texas, and decides to get after this pot of money versus NIH dollars, and we lose that opportunity to really build up people that need to have the preliminary data to be successful to get the NIH grant.
Agree.
Okay. All right, Wayne, you're next, and then
Yeah, just a few points. Maybe to address Israel's concern on 1B, could we change the wording a little bit so that drug intervention studies are not eligible for funding? I think that would keep you within the guardrails, being compliant with the wishes of the state. But what I'm worried about, the way it's worded right now, it would sound like we couldn't do any research on outcomes related to pharmacotherapy. And we certainly don't want to exclude that option. We just don't want to be doing, as I understand it, randomized clinical trials with drugs. Is that right?
Yeah, let me think about that and get with the conversations, but that I don't have an immediate opposition. Again, I think we have to have something related to drug studies, and maybe we just need to define what is, what it would be palatable by the legislature and which would not.
Again, my suggestion is just add the word intervention.
Okay.
Intervention studies. So we're not going to be funding any clinical trials.
Yep. Okay.
I think that's the distinction we want to make. And on terms of you're going to get a dozen different opinions on this, but where's the line about junior? Oh, yeah, there it is, number 3. I don't think it should be assistant or below, because below is an instructor. And, I don't think we're going to be having, I don't think the instructors are generally going to be ready to take a lead on a project like this. I think a compromise would be associate professor and below.
Okay.
I think there are, as Charlie said, there's some people in our systems who, for whatever reason, didn't get off the launch pad early, but are in a position now as maybe early associate professors where this would give them an opportunity to advance their careers.
Yeah. So Wayne, let me ask a kind of follow-up, if I may. So fellows, if you had a senior fellow that was doing work, do you think that they would be eligible or should be eligible to do something like this, so that they
I don't know. I'm thinking it should be for faculty, but we can have a discussion about that.
Okay. I see heads nodding different ways, so that'll be something that we will take a look at. Okay. All right.
That's all I had.
Very good. Thanks, Wayne. Peter, I see you're next.
I want to thank you. This is tremendously exciting for me. I think it's a tremendous opportunity for us small schools, and I want to commend you. This is just outstanding. I'm going to agree with Charlie about just make it translational research, and I think that gets you away from all the drug study problems. And I do think that there should be some mention in here about departmental support. So if the consortium will pick up 25%, then the department should probably pick up 25%. I mean, I think that that's kind of a reasonable contribution to this. And that's my comment.
All right. That's a new comment. Again, I know a lot of you do that. I think that's something we can, there'll be maybe not right here. We'll send some information out and gather feedback, but like to hear some support related to, or your feedback related to the obligation of an institution to also put in 25%. That does give us the ability to expand to more people. But again, we'll gather your information. Thanks for bringing that up. Molly, then Madhukar, and then Alex.
Yes, just a quick comment, and it may not be a popular one, but if a part of the goal is to expand on health services research in our state, I might encourage us to think if there are opportunities to engage other junior faculty that may be actively involved in research in school systems, in our LMHAs, in our juvenile justice system, et cetera, that are doing that health services research that may be more challenging for faculty in medical schools to do just because of the nature of those services, and maybe consider allowing some of them to apply for this research too, maybe even partnering, with representatives from the HRIs as well.
Okay. Yeah, let me think through that. I've tried to craft this in a way that's consistent with the statute, or what the statute says for us, which is the HRIs, but I think they could partner with other entities. I again, want to be careful that we are aligned with what the statutes area, what the statute tells us to how we can spend the dollars. All right, let me go. Let's see here, Madhukar, Peter, your hand is still up. I think that's from the last. So Madhukar, let me go to you, and then Alex, and then Jeffrey, and then Joseph. To Joe.
Thanks. So I think this is exciting. I have 2 points. One is thinking about it more structurally. What are we trying to foster? Is it the investigator or the research? And I am the PI of a KL2 from NCATS. We have 6 slots. We bank on the person, not exactly on the research, although the research they propose is evaluated. But what we found in that one is 3 out of 6 got funded first year. So in a way, going back to Charlie's kind of model, maybe thinking about investigators and thinking of this as a career award. They get 2 years or even 3, but 2 years. And I agree with Peter, because if that can be matched, because we want to bank on people who the peer reviewers think are good, but also for whom the institution has made a commitment. So therefore, matching funds from the institution, I think in my humble opinion, is more important. In our KL2, we demand that the chair support 25% of their time, and we support the rest. But that has really been helpful, because that becomes a more concrete support of the person. And obviously the research needs to be validated. So I think of which of the 2 you're trying to support may be worth considering in deciding how the dollars are given. And if you do career award, then you can actually spend money on more people. Because in a 2-year, maybe some research projects can be completed in such a manner that you can write an R01. In my humble opinion, for junior investigators, that's been very hard. So think of that as you figure out who should, but the idea overall is fantastic. So I commend you for.
And Madhukar, I'm gonna go to Charlie here, but I think you probably need to have some blend related to the research and the person. Again, I'm thinking of the KO8 awards where it's very focused on the person, but you need to be able to outline what the research project is to make sure that the review committee believes that there's meat there related to what we're doing.
I totally agree.
So then now I'll go to Charlie. Go ahead, Charlie.
Madhukar, I just wanted to say that there's a great differential among the HRIs in the ability for departments to support individual faculty, and demanding a matching fund would disadvantage certain of the HRIs, and we can't allow that to happen. So that's great if some of us could do that, but others can't support 25% of the faculty. So I think we need to be fair across the board.
Okay. All right, Alex, and then Jeffrey.
So given the length, 2 years, are these investigators allowed to have access to consortium data? Is one question I have.
I think they would, the consortium data under appropriate safeguards, but I think we could put that in place.
Yeah, because I think that would be huge for them to be able to, complete certain milestones in order to really apply for a larger NIH grant. So
I think that's a good point, and it could help maximize what we're doing. Anything else, Alex?
I think, can I just say about that point? I think that should be, Alex, part of the application. And the moment the application gets approved, because it will be approved by the consortium leadership, it will also approve the access that is required for each particular project.
Okay. Jeffrey?
Yeah, I have a few comments. One, lest I forget, in terms of the question Alex just asked, I would recommend not only that be permitted, but it actually be encouraged. That projects that are utilizing data collected from other consortium entities, and not just CTRN and YDSRN, but TCHAT and CPAN and so forth.
With appropriate safeguards,
Absolutely.
HIPAA compliant, et
Absolutely.
cetera.
Yeah, de-identified data, that sort of thing. So the second thing, getting back to who's eligible, I know at Austin, there's one person who's not faculty, is a nurse practitioner who's staff, who has considerable research experience, that I'm, working together with her on developing a grant proposal that I think would be wonderful for this. So I would not limit it to faculty. Although by and large, I think in practice, the vast majority will be faculty. But I also want to suggest one other thing, and that is several of the HRIs in their training programs, both for residents and fellows, have research tracks or research opportunities for trainees. And what seems to be common amongst those programs, not just in Texas, but across the country, is that there's funding available to support the residents' time that's already available, but often not funding to support the project itself that the research training resident is engaging in. And I think a set aside of some of the money, which would be smaller, considerably smaller than the $250 per year for some residents who are training in research. Something along the lines, I'm just pulling a number out of the air here, say $50K a year, could really go to good use. And I think would, if the objective is to have junior people working towards NIH funding, I think that would really be a solid investment.
All right. Joe, and then Jair, and then we're going to need to move on.
I was going to chime in quickly in favor of the idea of widening eligibility to include associate professors. You already have the caveat in there that they should not, that the applicants should not already have had significant external research funding. And in my experience, you'll find a number of people who've sort of come up through the clinical ranks for one reason or another, but they actually do have a lot of research potential. And I think that synergism of their dedication to research at that stage of their career, plus their ample clinical exposure so far, those are often people who end up as clinical associates. So I would favor including them.
Okay.
Another thing to consider, and I don't know if it's in here, but in terms of the real funding the research, but to the extent that there's really a career development piece, do we want to encourage folks to also get involved in, or participate in what their institution might have in terms of, the various clinical training resources. Maduker mentioned the KL2s or other things like that, where the institution is providing research training. Sort of a little concerned that, without that, then, we might have, junior people sort of applying at the behest of someone more senior just to, get them to, in essence, work on that senior person's projects without necessarily burnishing their own more independent skills that would be reflected in a high quality NIH application.
Okay. Thanks, Joe. And Jair.
So David, well, first, thanks for, putting this together. I think this is much needed. So I'm very excited, to see this being discussed here. And from what you're telling us, with a good chance of being approved. I will echo, so much of what has been said by my previous colleagues here. My main concern is actually not to have enough high quality submissions. So broadening up the scope, if at all, trying to stay away from, I guess, forbidding basic research and drug studies. Maybe, make this about like human research. I would understand. I mean, I don't like it. I would not prefer that. But if we have to stay away from like rodent studies, but conceptualize this, more broadly around human research being as encompassing as possible. Otherwise, we're going to exclude a lot of the work that very relevant, that could be coming. Making it available to associate professors as long as they've never been PI on an NIH grant. I think that is good. Very important to link these folks, with good mentors, and I would be more forceful to make, as part of like what's going to be assessed, this needs to result in an NIH grant submission. Otherwise people will take it, collect the data, and not go the step to actually put in the grant to try to get funded. But it's an exciting development. So thanks for putting it together. I think it needs to be polished. And the broader, the better. Otherwise, we may end up, with a very narrow lane where it's not going to be as helpful as it could be.
Okay. All right. No, I thank everyone for their comments. Again, as I noted from the beginning, this isn't the final. This is a starting point. I think we can take this feedback and adjust. Again, my red line is I need to make sure that I am using the dollars consistent with what the legislature intended the dollars to be used for. So although a lot of us would like other things to be funded, this isn't the NIH. This is a rare opportunity that we have, and so there are some nuances to how we put this together to be in compliance with what the legislature sees that we need to do. So again, I'll take this back, and I think at our next meeting have a next version of this based on this feedback that we will use to continue the process. With that, a quick time check from the team at the lunch. Is lunch here? Okay. So why don't we take a 30-minute break so everyone can grab something to eat. We have still a lot to finish on today's agenda with our updates from the COSH, and we have to go over the governance and a legislative update. I think we should be fine in getting done in time, but let's take a break now, and at 12:45 we will resume. Thank you. Yeah, thanks everyone.
No, wait.
Hey, David, I think you got to turn your mic on.
Both the room and you are muted.
Can you hear me?
Yes.
Okay. Oh, I'm sorry. Okay, this is my mistake.
So we're good. Let's start again. We're gonna go.
Okay, we're going to start at the top. Dr. Bobato. Here. Dr. Blader. Danette Castle. Dr. Chapa. Dr. Farmer.
Here.
Sonia Gaines. Dr. Goodman.
Here.
Dr. Harper.
Here.
Dr. Ibrahim. Dr. Johnson.
Here.
Dr. Keller.
Here.
Dr. Lakey.
Here.
Dr. Liberzon. Dr. Martin. Here. Dr. Martinez. Dr. Mayer. Dr. Mitchell.
Here.
Dr. Nemiroff.
Here.
Dr. Newport. Where'd Jeff go? Okay. Dr. Brittany Nichols.
Here.
Dr. Pliska.
Here.
Dr. Podewiltz. Scott Schlacklin. Dr. Scott.
John Scott here.
Dr. Suarez.
Here.
Dr. Thompson.
Here.
Dr. Vo.
Here.
Dr. Wagner.
Here.
Dr. Wakefield.
Here.
Dr. Wesley.
Here.
Dr. Williams.
Here.
And I'm here as well. I'm sorry, I missed the first call. Joe Blader.
Okay, so we have 21.
All right. Then we're good. Thanks everyone for coming back. We're going to jump into the governance of the consortium. There's a couple things that we need to make sure everyone is comfortable with related to the governance plan. And I think it's important that everyone reviews it because there's a couple of things that our governance plan says that we're going to be doing during the summer related to the executive committee and need to make sure everyone is aware and especially related to the elected positions with the membership of the consortium. And so Luann and Lachelle and the team have been working on the governance plan. You can see it in front of you. A couple of items that there is a bill that this document assumes is going to be passed, Senate Bill 850, which has a couple of implications related to the consortium. One, it takes out MD Anderson from membership, but it also adds an educational service center from a rural area of the state to be a part of the consortium. And so you have the the document in front of us, in front of you. Luann, you want to walk through it or anything that you would like to highlight?
I can walk through it. Most of these are logistical changes, like for example, assuming MD Anderson is removed, it takes the number of health-related institutions from 13 to 12 throughout the document. And then on page 2, removed the name MD University of Texas MD Anderson Cancer Center from the list. On number 4 from Senate Bill 11, we put, again, the representative of a hospital system in the state. And then we added, of course, the Educational Service Center from a rural region of the state designated by the Texas Education Agency Commissioner. We added some language on number 7 that basically just says any other entity the executive committee considers necessary. We added to fulfill the duties and obligations set forth by the Texas legislature. On the next page, we added a paragraph that adds our work associated with the federal ARPA revenue with the development of the perinatal psychiatry access network and the development of the expanded mental health workforce programs through that ARPA funding. We wanted to be sure to include that as part of our governance plan. Does anybody have questions so far about any of those items that I went over? Okay, then we go through the executive committee structure. We, on number 5, included that language again, representing a hospital system designated by a majority of the members, which are described in 1A, which is the chairs of the academic departments of psychiatry. We added again the Educational Service Center from a rural region of the state. And then on number 8, we put who are currently added representatives designated by a majority of the members of described in 1A, which are a representative of the Texas Education Agency, who is appointed by the commissioner, and the University of Texas system. We just wanted to clarify that those two entities are currently the two that meet that designation specified in number 8. Then on the following page, we just took out the language at the inception of the consortium because we are already operating. We did that on several of those paragraphs and just started it with the word 3 and eliminated that. And then we added the members described in subdivision 1A to clarify that section. And again, changed the numbers from 13 to 12. Changed the word will to may on those paragraphs. Does anybody have questions about any of those items? Okay. On the next page, we have consortium member representatives, and we cleaned up the language here. Just to clarify on number 1, we changed the word there to a members, and then on numbers 2 and 3, we specified the completion of the organization/hospital systems term without renewal as set forth above on number 2. And again, switch that to organization, agency, and hospital system on number 3. On number 4, we removed the words representative of an organization or agency and just made that the word member. And then on the following paragraph, added executive to the word committee, and then just changed some grammar to make sure that executive committee was capitalized. And on presiding officer, just change that from upon the approval to a majority vote. The following page under conflicts of interest, we just clarified that every 2 years, individuals on the executive committee and any work group members would document or disclose their conflict of interest using the form that we have had in place since the inception of the consortium. And then clarified that any newly appointed executive committee member will document also
and disclose any real or potential conflicts of interests upon their appointment and every 2 years thereafter. On the timing of elections, we took out the language that it would be the August meeting of the executive committee meeting of the fiscal year in odd number years, and just clarified that it would be the last committee meeting of the year. Of course, that probably likely would be August, but just in case, we just put the language last executive committee meeting of the fiscal year in the odd number years. Does anybody have any questions so far about any of that? Okay. And then on the very last page, under reports to the legislature, on the biennial report, we just simplified the first paragraph to say that no later than December 1 of each even numbered year, that the consortium will prepare a written report, and then we clarify what that report outlines. And then on number 2, added that the activities of the consortium, and number 2, the health-related institutions of higher education and any other entities that receive funding by the consortium, because there are some other entities that are not health-related institutions that do receive funds through the consortium. And then we added that last paragraph to clarify where the report that is written would be posted on the internet website and then submitted to the governor of the state of Texas, the lieutenant governor of the state of Texas, the speaker of the Texas House of Representatives, and the standing committees of each house of the Texas legislature with primary jurisdiction over behavioral health issues. So does anybody have any questions about any of those changes to the governance document?
So any questions related to the governance document, the edits that we've put in place? Okay. Seeing none, this is one of the items that I'll need to have a formal vote on. We need to have, the governance says for the governance documents for changes, we have to have 2/3 of the executive committee members voting in favor of them. And so again, I would take a motion from the floor to approve the changes that have been documented.
Second.
Okay, you got it. I got a motion here, Dr. Farmer. I got a second from Dr. Nemiroff. Any further discussion? Okay. Hearing none. All in favor signify by saying aye.
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 Opposed, nay? Did anyone abstain? Okay, so we have a unanimous vote from the consortium. I want to go back on a couple of items, and so we have approval here, but to remind people some things that we have to do based on this document, and these items really weren't changed from the last time. And I know this is maybe not the most interesting part of these meetings, but I think governance is important to make sure that we are doing what we said we would do. And I'll start with my position. As we talked about 2 years ago, I currently have the pleasure of serving as the presiding officer. That position has to be reelected every 2 years. So at our next meeting, we will need to have a vote to select the presiding officer. If anybody else is willing to do this or wants to be nominated, I would ask you to let Luann Southern know so that we can have the formal vote at the next meeting that we have. Another item is that UT System serves as the administrator for this. We put in the governance that we serve at the will of the executive committee, and every 4 years that administrative entity is voted upon by this group. UT System is still willing to serve as the administrator. If there's another entity that believes that they should be considered to be the administrator, I would again ask you to nominate yourself to Luann Southern so that we can have that formal vote at the next meeting. The bylaws also say that the nonprofit consortium members, that the term is 4 years. We have 3 nonprofits that are part of the consortium right now: the Meadows Mental Health Policy Institute, the Hogg Foundation, and the Texas Council. But that decision has to be reaffirmed or decided upon every 4 years. And so if there is a nonprofit, and we will let people know about this, that want to be brought onto the executive committee, we will have the formal vote at the next meeting to select those 3 nonprofits that are part of the executive committee. The hospital system, that is a member, again, that is another 4-year term. And again, believe it or not, we are at 4 years now. And so that position would need to be reaffirmed. And again, we will have a process so that if another hospital system wants to apply, that they can apply. Again, be transparent and follow our governance documents, but we'll have that application process made available to other folks. And then the additional consortium members, the only one that applies to is the UT system again. It has been 4 years since UT system was added to the executive committee, so that we can serve as the presiding officer, et cetera, and that would need to be reaffirmed in the next meeting. Any questions related to those items? Okay. Hearing none, again, we will send some of that information out, but again, we want to make sure we follow the governance document. And in order to be in compliance with the governance document that's been approved by this group, those elections and selections would need to take place later this year in August. Okay. All right. With that, we can now go, Dr. Williams, Laura, we can go to the update from the COSH on the various programs.
Okay. Hello, everybody. Hope you're having a good Monday. Decided to stop raining in Houston, at least for a minute, so we're happy about that. I'm just waiting for, I think, Edith, and she's already on it. She's gonna give us our slides. We missed out on my favorite holiday, but nonetheless, you still get to participate a little bit. I wanted to be Princess Leia when I was younger. Said I grew up to be a doctor. It was a win, but may the 4th be with you. Next slide, please. We're going to talk about some updates that are specific to COSH. Then we'll discuss CPAN. I'll hand it off to Dr. Wakefield for updates related to PeriPAN. We'll circle back to TChat, and we'll end briefly with Dr. Pliska talking a little bit about some information from the Data Governance Committee. Next slide. So we're very pleased and excited. As you've been hearing from some of the Luann and her team, that then the evaluation teams need to do a little bit of change and expansion. We needed to do the same thing for COSH in order to be able to really support our mission of supporting the 24 teams. So we have added 2 leadership roles that are similar in size and scope. And Jennifer Cole is going to be overseeing the Director of Operations for TChat programming across the state. And Edith Ortiz is staying, and she will be overseeing the operations for our CPAN teams across the state. We're very excited for Jen to be with us. She has a lot of experience in the public sector and working in out in the community, as well as really helping with operations, implementing school-based mental health programming. And so really feels like she's been here about a month, perhaps, yeah, a little bit more than that. And she's really been already instrumental in all the work that we've been doing, coordinating with Luann's team, as well as the 12 teams that are running TChat and the evaluator teams. So we're excited to have her on. So yay. Next slide. I'm going to talk about CPAN. So for WellNeti, want to let you know where we are with our database. WellNeti has been working very closely with the 12 HRIs, the team members that utilize this part of the service of putting in our vetted referrals, so that across the state we could collaborate with each other as needed. We have been working with representatives from each of the HRIs, along with Lachelle Amon, who has a lot of experience in sort of working with within these kinds of technology. And so we have, looks like a roadmap for updates that will improve the user experience and also for the CPAN team members themselves, but also for outbound to the actual PCPs, the letters that they get related to the vetted referrals. So we're looking like we're in our last sort of leg of this defining requirements phase, and we've already spoke to WellNeti about what it's going to take to make those changes. So once we get the final list of the improvements, then WellNeti will start working on it, and we'll have a clearer timeline, probably somewhere in the round of 6 to 8 weeks for them to make the improvements. And then obviously we'll have a rollout for training and updates with the teams themselves. So we're pretty excited about that. Next slide. For Lantana, that is the phone system that we utilize. One of the things that we have, as you know, discussed a few meetings ago was having getting rid of voicemail and instead having a voice recording that allows for the PCP to hear that and then move quickly to talking to a live person instead of possibly leaving a voicemail. That voice recording has been created, and now it's being reviewed by a number of the communications team, the executive team. And as soon as that gets finalized, then we will do the timeline for moving from the having a message left to this sort of live recording and hand off to another team if the current team is too busy. So we'll have more updates to tell you about that when it all gets approved. Next slide. So one of the things that people were asking about was related to the ARPA project that is around direct consultation. Kosh has been sort of supporting those teams that are currently doing the direct consultations. To date, since we started with the abilities of direct consultation, 142 families and primary care physicians have had the opportunity to have a direct consultation. Again, remember, this is not to start care. This is to help educate the primary care physician on the consultation question so that hopefully the young person can continue to be cared appropriately by the primary care physician and not necessarily have a referral specifically to a child psychiatrist that is hard to sometimes locate across the state. So we've had 142. I can tell you that 2 of the teams have been able to really hit the ground running from the outset and have had a really great show. They've certainly seen a lot of just individual increase in their utilization of CPAN, utilizing the direct consult with no sort of direct negative effects to their just overall being able to provide the telephone direct consultation. So we're excited for that. What we would like to do is make a recommendation to have direct consultation be available to any primary care physician, not just for those currently in these 9. I know that teams have been asking and talking about this from a budgetary perspective. We envision a process where teams would cover for each other. So we have this up here preliminary. It's not decided yet. This is just an example of what it could look like. So there'll be more conversations that occur. But for example, if let's say Baylor had their direct consultation on Monday, and that's the day that they're doing direct consultations, and their psychiatrist may not be available to take those phone calls, then the teams, Baylor and UT, would have a known process for when any calls that come in where a psychiatrist needs to speak to a PCP, the UT Houston psychiatrist would take that phone call and assist that primary care physician while the Baylor physician is continuing to do their direct consult. So that way there would always be providers in CPAN that are available to take those calls in the moment within those 30 minutes that we have as our baseline, as well as provide those direct consultations as needed. So we see this as a way to make sure that we're really being good stewards of the resources and really working together across the state, and why things like WellNeti and Lantana are very important, that we are operationally doing these things well so that we can have a seamless transfer when needed to sort of help a PCP wherever they are across the state.
Laurel, I have a quick question.
Yes.
I guess I'm confused. Is this covering when on the phone when the other site's not available at that moment versus the doing? I thought direct consults was when we set up the one-time evaluation. Am I getting the 2 processes confused here? Because I thought
no. So again, Baylor psychiatrists might be doing a direct consult, let's say on Monday from 8 to 10, and they're not available to take a phone call to the PCP
got it.
that wants to speak within the 30 minutes, right? So then the UT psychiatrist would take that phone call while the Baylor psychiatrist is seeing the direct consultation. So that way we can make sure that we're really maximizing our utilization of our physicians, and we're not needing to get additional physicians, because we think at this point we have the capacity to just cover for each other when our team might be doing a direct consultation.
Good. And just a quick note, UTSA is the Roadrunners. That's our undergrad campus. We are UTHSCSA. That's a big deal down here. So
Sorry.
for the next slide.
We will make sure we get that improved.
All right, very good.
So again, if there are teams that end up just electing to not do a direct consult, we would still be encouraging for that region of PCPs to have the opportunity for a direct consultation, and that would potentially move to one of the HRIs that is providing a direct consultation. So far, it's gone well for those teams that are doing the direct consultations. They've been able to get another team to provide that phone conversation when needed, if their psychiatrist is busy doing a direct consult. Questions? Next slide. So this is just a rundown of things that our vendor for the data capture and analysis, not analysis, but data capture is done. We've had the build out for PeriPan all completed by January 2023. You can see that I'm not going to read this out to you. You can just look at it. And I'm just talking a little bit to give you enough time for your eyes to peruse it in case you didn't look at them a little bit else. Next slide. So one of the things that is in development are sort of improvements for the CPN, and we have in development medication recommendations. So this is the second part of the call form where the psychiatrist is involved with, or the NP is involved with talking to a PCP about our recommendations. That is in its final sort of review by the physicians themselves, the psychiatry physicians, as well as the evaluator teams and the executive team that the UANs run. As soon as we get a go ahead from that, then it will move forward. Medication history improvements, that is also in development with the same group of people. We've definitely made progress, and we expect this to be done within short order. And then the second call form part 1 improvements, some of those actually are slated to occur on May 24th. 2 things that the team members wanted is actually going to be out May 24th. The rest will be out June 2023. And then call form part 2 and 3 are a bit of a sort of duo, because one of the things we're probably doing for the direct consultation documentation is largely utilizing the what's in call form part 2 with some just additional data capture elements. So we're trying to define those with those work groups and bring that forward to the relevant parties before it moves into development and scoping. We also are working on, this is one of the ARPA projects related to the web portal. We have already done focus groups with primary care physicians who are currently utilizing CPAN to understand their whether or not they would be interested in having an additional way to put in a consultation, as well as to get the information from the direct consult to them after the call or the consultation. So far, that group of providers have been overwhelmingly positive about the idea of a portal. We feel like we need to do due diligence, though, and try to reach out to CPAN PCPs who have not yet used the service to see if this would be something that they would find beneficial and it might cause them to utilize the service. So we're still working to get those focus groups up and running, because we want to make sure that we really blanket providers across the state before we go and build. So that's why that one is to be determined. Next slide. So moving on to the dashboard. So it's going to switch from one thing to the next, and she's already there. We're just going to do CPAN first. Sorry. Thank you. So I just wanted to point out that we are, again, we have set the bar for consultations within 30 minutes to be 90% or above. As you can see here, we're at 98.8% of the time, with our median response time of a child psychiatrist speaking to a primary care physician, 4.7 minutes. So we're doing extremely well there. We've had over 20,000 completed consults with an estimated 18,500 patients served. So we're very excited with that. We've been collaborating with the evaluator teams, specifically David Lynch, related to the provider list, and we'll have more information to update you related to providers across the state who are enrolled in CPAN. So we'll kind of move down to the middle part of the slide where everybody wants me to go. And as you can see here, we've had steady growth in CPAN. I just want to congratulate all the teams. There's been a lot of concerted efforts of outreach. Melanie with Suswine, with the communications team, has been enormously helpful to all the teams. And so you can see starting in November, we've had just a steady increase month to month with the number of consultations. And so we're very pleased to see that. March was technically our best month ever with over 12,000 consults. We had a slight dip in April, but still extremely impressive. I have been speaking across the country. Actually, people have wanted to learn more about the consortium and CPAN. And I can tell you that people, I was recently speaking to some folks, I think in Illinois, and there's just a lot of interest in the great work that's being done in Texas with the consortium, and specifically with CPAN and with TChat. So I just want to commend all the teams for all of their lovely and hard work that they've been doing. We're very excited for that. And then I'm going to stop sharing. Is this where we need to switch over, Edith, to PeriPan? Yeah, so we'll go to your slides first, Dr. Wakefield, and then we'll go to the dashboard when you need it to. Okay.
Oh, great. Yes. Well, I have my slides ready to share, but I will end my show and I have the dashboard up too, but we can definitely use yours. So next slide. Just to give an overview that we are at 43% enrollment across all of the HRI pilot sites, which is really impressive and we're excited about. These are the OBs in the region, the specific regions. We have engaged each site, each HRI who's in the pilot region to talk about how to improve their enrollment, specifically looking at some of the larger hospital groups to bring them on board. Next slide. We are still seeing, almost half of our phone calls be about medication. And then in addition, we're seeing about 2/3. So those aren't exclusive. Some are asking about medication and referrals for services, but a lot still asking for medication recommendations related to the patients that we're seeing, which is a little higher than we saw in CPAN, even from the beginning, where we kind of looked at 2/3 and 1/3. So we're really excited about how we're supporting OBs and family medicine docs in the frontline care of their patients. Next slide. So I'm excited about this slide. It demonstrates that we are increasing our number of repeat callers. So we still have the majority are calling for the first time, which is to be expected, but we really want to see this red bar increase over time, that people are calling back because they found the service useful. So you can see we're up to 33% of our calls are repeat callers. Next slide. And this is a really exciting thing that we've launched from the beginning or near the beginning with PeriPan are our educational opportunities. And we've had our webinars, and also we have launched our Project Echo, which I think many of you are familiar with, or most of you are familiar with, the Extension for Community Health Outcomes, which are collaborative learning networks within, and these are offered to the pilot regions as they stand right now. The webinars are offered statewide to all clinicians, all providing perinatal care and postpartum care. And we have had several webinars already, and we have launched our Echo this month. So we were very excited about that, with our second one coming up next week as well. And I am so grateful to all of the perinatal or the PeriPan educational curriculum is a little bit different than the CPAN Echo and educational curriculum, where we had different HRIs developing curriculum and kind of giving it on their own for the webinars. And then the Echo curriculum was something that we got from another entity and customized it for our state. There wasn't any such opportunity out there for reproductive psychiatry and perinatal psychiatry. So I owe a great debt of gratitude to all of the experts across our HRIs, especially in those pilot sites. They have We developed a curriculum, recommendations on what were those core topics that should be included for obstetricians and family medicine docs and pediatricians, and came to a consensus about what that looks like, and then what should be included in a webinar series, what should be included in an echo series, and all of those experts developed this content, and that is what's being delivered. Next slide. So just want to show that we are increasing our webinar activity as well. In the first month, we saw 58 attendees across the state. You can see that some of those, about a little over half, were in those pilot regions that we were engaging, but at least a quarter were outside of those pilot regions. We are reaching clinicians who they're actually getting statewide opportunity to participate in these webinars. And so if you are at an HRI that is not currently participating in PeriPan, we do want you to know that this is an educational opportunity for anyone in your region or any of your clinicians at your HRIs as well. There was a study done a few years ago that showed general psychiatry trainees get about 6 hours on average of reproductive and perinatal psychiatry training, despite that women make up a large part of the population that we treat in practice. So there are lots of people who could benefit from this education and training, and we're excited to be able to invite all of your clinicians and staff, and not only at your HRIs, but in your regions. So you can utilize your CPAN mechanism to let them know, because this is one of the target audiences are the pediatricians and family medicine docs as well. Next slide. These are upcoming webinars that we have. And I think that is the last slide. Is that the last slide? Yes. So do we want to share? I was going to start the dashboard down in the purple. So I have mine up, Edith, or you can share yours, whatever is easier. Yes, if you'll move down to the purple for me. Great. All right, so we also had a little bit of a dip in April, and obviously our call volumes are not as high as we've seen in CPAN right now, much different stage of the project, but we have seen some shifts in that as well. And you'll scroll down just a little bit to that next section. Actually lower than this. Yeah, because I included all of that. I wanted to talk a little bit about some of the things that we're seeing actually in PeriPan perinatal characteristics, please. There we go. Okay. So a lot of the women that we are seeing, the majority of the women we're seeing are either pregnant or postpartum. We have gotten a few calls about preconception, and then some post-loss as well. Average gestational age, about 20 weeks, average weeks postpartum, about 13 and a half, and then weeks post-loss when we're consulting on those cases, about a couple of months. I think if you can scroll down just a little bit. Yes, we are. So I wanted to just show people that we are collecting additional data points really in obstetric risk factors that we're seeing consulting with women who have hypertensive disorders and prematurity, diabetes. All of these we know have worse outcomes when their mental health is not adequately treated and supported. So we're happy to be providing this care for women and collaborating with their clinicians to do it. I think that is all I have.
Thanks, Sarah. We can stop for a second and just see if there's any questions related to the PeriPan work at this time, or if there's any of the other HRIs that are part of the pilot that want to add anything. Dr. Trivedi?
So this is related more to Laurel's presentation. I think you're doing a whole lot of great things, but you're standardizing your letters to the providers, I think, is a wonderful idea. It has many major benefits, but one is you're really sending uniform comments back to them so they can use it. And it also reduces some of the bias and stigma that a lot of this is hocus pocus. So kudos to you for doing that.
Thanks, Madhukar.
Thank you, Dr. Trivedi. I do want to say that one of the things we've launched from the beginning also with PeriPan, because we saw it was such a vital thing for CPAN, and heard from our other entities across the nation who are rolling out these programs, how engaging it is and what a vital service it is for the frontline clinicians, that we've started that in PeriPan. And so modeling a lot of that, able to learn from those things that happen in CPAN. And we have also provided a direct consult guide, or working on that direct consult guide, in addition to the toolkit that Melanie referenced earlier, that will be available on the website. So we are really excited to learn together and provide these things.
So thanks, Sarah, again, for all the work in putting this together, and all the other sites are involved. You know, this is a pilot. We're learning from the experience. You know, the money is in the budget if it's passed related to statewide rollout. I do think we're going to need to look at our experience and figure out then what the right size of this is. Again, I'm not, you know, it doesn't bother me that we're at 40 right now. I think this is the nature of a new program that's being rolled out. We saw with CPAN, you know, it took a little while for the numbers to go up significantly, and we'll continue to watch that. But we will, you know, as the dollars are made available, we'll be working with all the institutions to figure out kind of what the right size of this is as we roll out for the statewide rollout. I know there's some HRIs that don't feel like they're capable at this time of providing this service. There's a lot of education that needs to take place, and that's why these webinars are very useful at this time.
Well, and
So,
Dr. Leakey, can
yeah.
I mention
Yeah.
also that one of the things, because general psychiatrists sometimes don't feel like they have this expertise either, and because of the limitations in training that I was talking about earlier. But one of the things that we want to do and that we are working on right now is actually utilizing the national curriculum in reproductive psychiatry and making that a learning collaborative among our health-related institutions. So a higher level of training in reproductive psychiatry that is the national standard in reproductive psychiatry training. And so right now we're really focused on looking at what those modules would look like, how much time it would take. And I want to just, you know, we don't have all of those factors fleshed out just yet, but I wanted to let everyone know that we are looking in that for both clinicians, like faculty clinicians who are interested in improving their knowledge base around reproductive psychiatry. We think it's an opportunity for our child psychiatrists who are currently working on CPAN to be able to expand their knowledge base as well, and potentially answer questions for both of those services in the future. But additionally, we want to provide this national curriculum in reproductive psychiatry for residents. And so we will be contacting some of the resident or all of the residency training directors for this opportunity. Of course, it's not anything mandatory, but if you feel like this is an area in which your residency program does not have the expertise, we want to help provide that curriculum support, because this is such a vital need in the baseline expertise of any psychiatrist.
Very good. Yeah, there continues to be a lot of interest in the maternal and child health folks that I work with, the OBGYNs, wanting to see this to continue to roll out statewide. And again, I think we're going to have that opportunity and just continue to build on the momentum. So thanks. So Laurel, let's go back to you to finish your update on with TCHAT.
I'm just going to say, I guess, two things. One is for CPAN. We are working to kind of standardize a number of things, Dr. Trivedi. And I think that, again, the goal is to make sure that no matter where you are in the state of Texas, you'll get the same high quality information and services. And we want to make sure also that the teams are working in a collaborative way and working to work with each other, so that we're not sort of just 12 separate entities working and operating differently. All the teams are working very steadily on outreach, and I think you can see the efforts there. And that outreach is also coordinated with PeriPan. So we are not going and doing a bunch of outreach and not talking about both programs. So when we see a pediatrician's or family medicine practice office, we're talking particularly in those areas, 4 areas, they're hearing about both PeriPan and CPAN at the same time. Obviously for obstetricians, that's different. That's a new constituents that Dr. Wakefield is specifically targeting with outreach, but we are also integrating in that fashion as well. And we are utilizing Melanie's sort of communication plans to sort of organize our outreach on social media, in our newsletters, on the webpage. So all those things we're really working to collaborate with each other and have clear messaging around sort of the areas for CPAN. So it's been a lot of work, and all the teams are to be commended for all of their monumental efforts. But Melanie in particular and the executive leadership team have been so very transformational in sort of getting our numbers to be kind of steadily rising. So we're very excited for that. For TCHAT, we're just going to talk about two things relatively briefly. So moving on to the next slide. This, as you can see, here's a number of referrals across the last 2 years. Now, these numbers are preliminary. They're subject to change as the evaluator teams review, but they are, generally speaking, we're kind of where we are at the moment. And you can see there's been tremendous growth to that point. I also want to point out that the teams have been working really hard to ensure that they are seeing kids within that sort of urgent status and working on that piece very, very proactively. And so I think we're all potentially having struggles at different time points with hiring a number of the people that are on the front desk, people that help with getting the person in the vital signs in the room, collaborating with the schools, the coordination with that effort, as well as getting the therapist to be participating. There's a number of sort of places in there that there's a lot of coordination required. We also have been working very closely with the HRIs and Luann's team with the data that Lachelle is helping put together, working with the education support teams. So we are really working to get in front of people and ask, have them understand what TCHAT is about so that we can help them make decisions would they like to have the service or not. But as you can see, the referrals continue to climb as more schools, districts are onboarded and more schools start to utilize the service. Next slide. Again, the same caveat about data exists here as well, but again, you can see a pretty enormous growth in the number of sessions per month we're providing, I should say encounters, but again, encounter can include more than one session. Most of the time it is just one session per day. But if, for example, a physician and a therapist saw somebody on one day, that would be one encounter if it were one session. So it gets a little tricky sometimes with the definitions, but nonetheless, a lot of additional increased growth for TCHAT, which we're very excited about. And I'm going to turn it over. I think this is the last slide. Dr. Pliska is going to speak briefly, is my understanding. Oh, yeah. Yes, as he's getting ready to start talking, we had some slides just to share with you about some of the work that the vendor is doing for trade, or what trade's doing. So we are working to automate some of the assessment that was recommended to include related to functioning, impairment, so that's the Columbia Impairment Scale, as well as a number of other sort of implementations to make sort of processes work more smoothly for data purposes. So we're excited for that, and we'll keep you up to date. The big one that Dr. Lakey and team, I should say, has been asking around is medications related to TCHAT. That is actually currently being developed within trade, and the expectation is that it'll be ready before the next school year for the whenever there is a physician is seeing a young person with family consent in TCHAT, that we would be talking about what are the medications that the teams are providing, always with parental legal guardian consent. And now I am going to turn it over to Dr. Pliska, who wants to talk about some things within data governance.
So at the last executive committee meeting, there was a vote for the Data Management Governance Committee to explore uniform assessments that would be across all HRIs. So the data committee met, reviewed a number of measures. They were chosen for their how practical they are, and also those that aligned with what the TCHAT Operations Committee had requested. So after then further discussion with the TCHAT Operations Committee, we defined these measures, a set that will be done entirely at baseline. We would estimate that if they're done all at one time consecutively, it would take about an hour. Those measures that were elevated in the clinical range, they would be repeated at follow-up visits at the same time that the Columbia impairment scale is currently being done. And the next step is to go back to the Teach-Out Operations Committee and kind of discuss some of the nitty-gritty logistics of how this will be done. We want a protocol that is flexible enough that it fits everybody's particular method or design for Teach-At, but at the same time gets it all in a uniform manner, so that we will have outcome measures assessed consistently across the state, and that therefore will have the power in order to look at any number of different questions. So the next Teach-At Operations Committee is there one coming up in May, or is there and what's the do you have the date on that offhand, Laurel?
Next May 26th.
Sorry, May? I didn't hear.
May 26th.
May 26th. Excellent. Yes, May 26th. And so after that, we hope to get final consensus, then bring that to the Data Management Committee for final vote. And at that point, we can kind of start planning for implementation, and set a date, what would be the start date when we would actually do these things.
And Steve, I would ask one additional step, after that committee meeting, if you could bring that to the executive committee, so that everyone here feels comfortable with what's being put in place. I think it would be useful. Okay.
That would probably be most likely the July meeting if we're having one.
Let's put that on the agenda for July.
Okay, that'd be great.
Okay. All right.
All right, that's all I have.
And any updates on CPWE, Steve? Is there anything that you need to bring?
No, everything is moving along. There have been no unusual difficulties. I guess the big issue is querying the residents about their experiences and tracking that. And David Lynch with the internal evaluation team is coordinating that. And if we wanted it at a future meeting, we could get a more detailed report on where that's going.
Okay. All right. Any questions for Steve? Nope. All right. Very good. So let's go to the last item, the update from the legislative session. Sean can't be here. He's been pulled downtown to be in some smaller meetings with some legislators on a couple of things. So I'm going to pinch hit, but mainly focus on the budget. That's where we've concentrated a lot of our time and energy. For those of you that haven't been following how things have been going, the House passed their budget, the Senate passed their budget. In both of those budgets, they put in what we asked for. And so those two budgets for the consortium are the same. They have in House Bill 30 put in, what's that? Senate Bill 30, which is the supplemental bill. They have given us the authority related to carry forward for ARPA. And so when you add those two things together, we are fully funded. We will have, when you add those things based on the initial analysis, it comes out to $337 million for the biennium. It looks like we're going to have a little bit more ARPA dollars than that. And so, and the importance there is that there's some things that we can pay for ARPA, and there's some things that we can pay for with GR. Prairie Pan, we need to pay for that with ARPA. The language that we need in order to allow us to provide care to women, that's in the ARPA language. That's not in the statute that authorizes the consortium, and it's not in the rider. But when you put those two things together, we will have the funds to continue the pilots that we started under ARPA, to do the workforce initiatives that we anticipated that we would do, to expand Teach-At to all areas of the state. We will be fully funded, and fully funded means that we base that on water institutions told us that they needed in order to carry out the mission. We bundled that together. We got from you the various workforce initiatives. And again, they are identical on both the Senate side and the House side. So that means that that they are relatively safe right now. Nothing is final until the votes or until the bills are voted off the floor and then finally signed by the governor. But because they're the same, and we did that work prior to the session in the base bills, that they don't come up really for discussion during the conference committee. When there's differences in things between the two sides, those are the things that they focus on. Since they are the same in both sides, they really won't come up for discussion. And so we feel pretty comfortable right now related to where we are on the budget. And again, we will know for the final decision by the end of this month. In the meantime, there's a variety of policy bills that we have been involved in. We've talked about several of them today. Senate Bill 850 takes MD Anderson from the executive committee. It adds a educational service center to the executive committee. There's a variety of bills related to parental consent and telehealth, and we've been trying to navigate those waters. There is a House Bill 400, which will provide funding for medical schools to expand psychiatric, both children and adult psychiatric training programs, and also has a special area related to forensic psychiatry. And we'll share that with you at the next meeting. If you haven't seen that, you can go to Texas Legislature online and bring up House Bill 400. But those dollars don't come through the consortium, but will become available to the medical schools across the state. And there are a variety of other items funded in the budget that, again, that don't come through the consortium, but will be, I think, of benefit for the mental health system in the state of Texas, for nurses, for other areas of workforce, money at HHSC. Luann, is there any that you want to highlight?
Well, I think I sent the executive committee an email early on in both Senate Bill 1 and House Bill 1. HHSC would be appropriated additional resources to support the development of children's mental health services in the state of Texas. I don't think Sonia is on right now, and I don't think Danette is either, but Andy might know some of those if he's on. I know one would be expanding multisystemic therapy programs across the state. There's one that would appropriate resources for adding mobile crisis psychiatric emergency teams for children. Another one would create an innovative grant program for the development of services to prevent young people with mental health needs from going into the juvenile justice system, preventing parental relinquishment of custody in order to receive children's mental health services and other types of innovative services. And so those are just a few of those. I don't remember all of them at length, but some of the rest of you might know. Andy, I don't know if you're still on, but I know you've probably been very involved in also keeping track of those. If you're on.
He has his hand raised.
Oh,
Yeah,
that's good. Okay.
I just want to relieve your those here. Yeah, I thought you gave a great overview, Luann. I would just maybe note a couple things. One is there's a very specific package of intensive services that are designed to be for the consortium to refer to. I mean, I think we were very clear with folks during the interim when we talked about the impact of Uvalde, but more importantly, the impact of violence on children more broadly, including suicide. That, while TCHAT's fantastic, we need more intensive services for many of these youth. So I think it's important to think of those three sets of services that are in the budget that are being ramped up basically as fast as possible. The MST, the multisystemic therapy services, there's going to be 23 new teams coming up, and those need to be really developed and then aligned with us so that we can get youth that are in need to them. There's going to be funding for 18 new coordinated specialty care teams, which is for early psychosis, which most youth don't have that need, but many do. And so being able to access those that are particularly focused on youth. And then these youth mobile crisis teams, there's going to be 5 new teams that are developed that are really not like, these aren't like the mobile crisis teams that the local mental health authorities provide, which are fantastic. But these are really designed to be not just crisis, but urgent treatment care. So if you have a family who really needs to either stay within a foster care placement or maybe stabilize post a visit to an emergency room and needs ongoing intensive support for 60 to 90 days, these are really these sorts of transitional teams that, again, we could potentially have TChat referrals to. These are, not what we need for a full statewide implementation, but the state very thoughtfully worked with HHSC, worked very thoughtfully with the committees to say this is probably the max that could be done. I would also add that none of these teams will be able to be implemented unless the state makes good on the need to increase rates paid to local mental health authorities so they can actually stay staffed. So the state did some wonderful work prioritizing funding in the base budget for state psychiatric hospitals. They put no money in, despite excellent efforts by people who know us, by not us, but know y'all in HHSC. There was no money recommended by HHSC officially for that. How fortunately, Tony Rose from Dallas and other legislators saw this gap, worked with the House Appropriations Committee to fully fund a rate increase for the local mental health authorities. That's in discussion right now with the Senate budget conferees, and we hope that that happens. If there is not a rate increase for our local mental health authority partners, they're going to be tremendously hampered because it's very hard in this environment with the existing rates to compete for staff. So that's really important that we know that. And I think, David and Luann, it would make sense once this happens post-budget to talk to our friends at HHSC, our friends of the council, to talk about how we can make sure that there's strong linkages for us to be able to refer to these new teams as well as the existing teams, because the youth we're serving need it. And this is what the legislature is looking to us to do. The only thing I would add that I didn't hear you say, Luann, was that there's also going to be a considerable amount of money going to new state psychiatric hospitals. And while most of these are focused on adults, many of them do include youth serving components and youth components. And there's also going to be $100 million to start up new facilities in partnership with communities, and not just hospitals, but also crisis stabilization units. There's also our expanded funds for purchasing psychiatric beds in communities, which could include youth serving beds. So I would really encourage you with your local mental health authority partners, because they'll be the lead in implementing all that within your region, to look at how you can make sure that they're taking into account the needs that you see through your TChat programs in particular, but also through CPAN and other programs you offer. So because I think this is a historic investment. It'll be in the billions of dollars. It'll be the largest increase in mental health funding ever in the state of Texas. And it's one that we need to make sure is there, because we can't do everything through TChat. We got to be able to have these other folks to actually serve the more intensively impaired youth and families. So I think those are the main ones, Luann, but other people certainly have been in the middle of this and may want to highlight some others, but those are the main ones we're tracking.
I did think of one more thing, Andy, and that is the development of a statewide children's mental health strategic plan that would lay the groundwork for really looking at the full continuum of what is needed for children's mental health across the state, all the way ranging from prevention to inpatient hospitalization and everything in between, where we're at as a state in terms of funding, in terms of services and accessibility. And HHSC is the agency that will spearhead that, working with the statewide behavioral health coordinating councils, one of the committees of that council. So that's another thing that would lay out that kind of plan for looking forward.
So for those of you that haven't been involved in legislative sessions, the next several weeks are really important. Last week was the week when things started to die. And so lots of bills died because they didn't meet certain benchmarks, some gates where things had to be voted out of committee or off the floor. There will be more bills that will be dying this week and next week. But in July at our meeting, we should have a good landscape and be able to provide everybody kind of what happened, what didn't happen, and in particular our budget. And we will be spending a lot of time with you this summer making sure that we go back to you to understand after 8 months, when you provided us what your initial thoughts were, how those have changed. Again, I think on several of these items, people may have thought they could do things that they may not be able to now. And we will need to look at that and readjust budgets to make sure that the dollars are well used across the state, understanding the mandates, not mandates, but the expectations that the legislature has on us, especially with TChat and several of the other initiatives. Any particular questions? And I know that it may sound a little gray. It's just the time of the session that we're in, where this is a really important time period. And a lot of our folks are actually down there at the Capitol right now, trying to move certain pieces of legislation forward, provide the information that's needed, and to help provide input to the legislature. Okay. Any questions? All right. If not, I think we have completed the agenda for the day. And with that, Luann, anything from you before we finish?
Well, May is Mental Health Month across the United States, and I just want to take the opportunity to thank all of you for all that you do every day for children with mental health needs and their families across the state of Texas. I think because of what you do, those families know that mental health is treatable, that you can recover from it, and that you can be successful. And I think that everything you're doing is helping families thrive and children be able to be successful in school. And so I appreciate everything that all of you do out there. Thank you.
All right. Michelle, anything from you?
Yeah, just one thing really quick. I wanted to share. So this was pointed out to us recently. There was this report of Council on Medical Education, and I just wanted to give a shout out to the consortium and also to Dr. Lakey, who was mentioned in this. So we'll share it with the group, but they just had a lot of good things to say about us, and then about you, Dr. Lakey. So.
Well, thank you. It's a privilege to be part of this group. Thanks for allowing an old infectious disease public health guy to be part of the conversation. All right. With that, I again give everyone back about an hour of your time, and the next meeting is going to be important. And so again, encourage everyone to be here. As many of you that can be here in person, that would be great. Again, there's a lot of things that we need to go through to position ourselves well to be ready to run with the new dollars come September. And so it'll be an important meeting, and I look forward to seeing you there. Thank you.
Thank you all.
We're ready to give you a certificate in psychiatry, Dave.
Yeah.
Honor.
Bye, y'all. Have fun.